Okay, guys, very good morning. Super excited to be here in Bengaluru and taking a class for you guys. So, what I'll be doing is talking about a couple of topics which NNL has told me to take. Specifically, I think central nervous system is one that is pending. So, we'll start with CNS, central nervous system, which people usually tend to be a little, jittery about. But I'll try to simplify things and explain it to you in the best possible fashion that I can to my best of my ability. And all I would request you for like this particular exam is that you need to put your heart and soul into it. I mean, you need to put whatever you got because I think at 22, 23 years of age, most of you 18 plus 4.5. So 20 to 23 years of age is a very ripe age to actually learn things and, you know, I mean, get a job as early as possible because once you cross that age of 25, that's what I've seen. That this is what happened with me. Once you become older, your ability to remember things and your ability to study long hours tends to decrease, and family members are more interested in your marriage and a lot of other things, right? So family members would be saying, I mean, how long are you gonna study? You started biology long back, 10th class, 10th, 11th, 12th, and all these, 4.5 years into a nursing school. So the grind is really very crushing, the number of hours that we have to do and number of hours that we have to put in duties is really very, very, intensive. And what I can say from my personal experience is that every doctor, every nurse, uh, you take sadness from people, right? When you walk into a ward, like let's say Bangalore is a place which is known for corporate. So when people walk into a corporate office, the walls are all very bright, yellow and I mean yellow and blues and pinks. And then when the day will start, people will first go to a coffee vending machine. But doctor and nurses will not go to a coffee vending machine, right? You will go to a patient, and patient will be sick. So irrespective of whatever your health is, I remember a day when my child was sick, I still went for duty. Your mom could be sick, you will still go for duty. So a doctor and nurse is basically taking sadness from the person. So you are basically that noble soul who's taking negativity from other people and still be positive at the end of the day. That's the best thing about us, that we take negativity from people and we can still be positive. I mean, that requires a willpower to create, or I would say willpower to be positive on a regular basis. So anyway, I'll keep on doing chit chat, and what I can say is this is the age when you need to put max of your efforts so that you become financially independent, because that's a very important thing. Once you cross that particular age group of 25, that's what I've usually seen. People tend to lose the drive to study. And then it's like, just only for the heck of it. But at this moment, you are fresh out of college. So I think if you can put in your best efforts in the next couple of months, you are sorted. And central government job is a dream, right? I mean, gradually, once they stop opening all these aims and everything, then these jobs will dry up. Like, in all government sectors, saturation is there. I mean, there's no government jobs available, right? Private, obviously, new hospitals are opening, but then private hospitals will exploit you now from the salary perspective. I mean, the salaries are obviously on the lower side, and central government jobs, the salaries are good. So that's one of the most important things, financial activity, in my opinion. It could be saving a life, it could be taking negativity of a person, or simply making money, whichever way you call it. But there has to be something that has to keep you alive at 3 o'clock in the night. When at 3 o'clock, your eyes are going shut and you are saying to hell with everything and I don't want to study, and you want to dump your books. There has to be some motivation drive that keeps you awake for another half an hour, because remember my words, whatever may be your maximum studying capacity, for your rival, that may be his minimal capacity, right? You might be saying I'm studying 8 hours, the other guy is doing 9 hours, 10 hours every day. So more number of hours would mean that that person will be more comfortable solving MCQs and attempting, and there would be some people who would be going for second attempt, third attempt also. So if somebody is going for second or third attempt, they will be having more knowledge than you, so you're competing with best in the country. You're competing with best in the country. So you need to have that, that aggression in you. So if you think that 8 hours is sufficient, no, it is not. I would say, like, I'll not put a number to that, but I can tell you that you need to increase the number of hours into double digits. At least that is what is required right now, double digit study, apart from, the routine classes that you're attending. So classes would be 7, 8 hours, then another 10 hours of study. So obviously I'm saying very outrageously high numbers, but people do that, sir. People do that, 15 hours of study, 16 hours of study. I mean, I can see it in the eyes, that fatigue, the tiredness. I mean, I talk to students and they say, like, some people, right? They studied so hard that they are always sleepy. Not in the class they are sleepy, but they studied so hard that they're sleepy. They say, sir, you give me an opportunity, I can sleep on the floor. There might be people who will say, I am tossing and turning in the bed in a very comfortable bed. But when you really work hard, now you can sleep anywhere. You can sleep even sitting on a chair. We all, like, if you have done night duties in a hospital, we do sleep for 5 minutes, 10 minutes, sitting on a chair. No, that fatigue comes in and still you are able to sleep and feel fresh. So it's all about, that tiredness should come at the end of the day. And how that tiredness will come is not from scrolling internet. No, we usually like go on Instagram reel, one after the dopamine hit coming, and then we get tired and then we drop dead. So it's not to be like that. It is studies that matter. So anyway, this preaching part and everything will continue. We can start for today. The first topic that I'll explain is from central nervous system, and what I'll explain to you from the CNS domain. What I'll explain to you from the CNS domain is a easy topic that is called as Guillain-Barré syndrome. So neurology is the first thing that we are going to be taking care of. What are the important topics that they love to ask you? You do have booklets available. I wasn't aware that you're having booklets. Okay, doesn't matter. So what I will do is I will keep on doing extempore topics in front of you. This is an easy one that I can explain initially. That's called as Guillain-Barré syndrome, because patients will be requiring ventilator support in this one. And there was an outbreak of Guillain-Barré syndrome in Pune last year. So let me explain what really went wrong. So in Guillain-Barré syndrome, guys, the basic problem in the patient would be mainly that when the person will come first time, he will not be having any paralysis or weakness or anyone or anything. What the person will be having is rather maybe food poisoning. Like this particular individual, he had had a chicken sandwich. Now, you know that in a hot Indian summer, chicken can go bad, especially if the sandwich is having mayonnaise in it. Then mayonnaise, again, the milk-based products can go really, really bad. So I am having a patient who came to the hospital with complaints of food poisoning. I mean, that's how the case presentation can actually begin. The organism which is responsible for causing development of Guillain-Barré syndrome happens to be Campylobacter jejuni, and the presentation is that of food poisoning. That's going to be nausea, vomiting, a bit of fever, maybe loose motions could be present in a patient. So what I did is, when this patient came to me first time, I gave symptomatic treatment. By symptomatic treatment, I mean, like, because the patient is having multiple episodes of vomiting. So you know that one of the common drugs that we use for control of vomiting would be like domperidone. And if the person is having simultaneously loose motions, we can give ORS to the patient. So we'll talk about dehydration component separately. But at this moment, it was like a mild to moderate food poisoning that was present. So symptomatic treatment was given to the patient, and the patient showed clinical recovery also. Like after 1 or 2 days, this patient called me back. He said, Doc, I had taken this treatment for food poisoning from you. After 2, 3 tablets only, I have improved. So do I need to continue the treatment? I said, no. If you have improved, then you can stop ORS and you can stop the tablets and you're doing fine. So there is a complete recovery in this particular individual from the food poisoning perspective. And at this moment, I don't know what is going to happen to this guy 2 weeks from now, because in Guillain-Barré syndrome, there is production of antibodies. Obviously, in any infection, antibodies are produced. In any infection, antibodies are produced. But what happens in Guillain-Barré syndrome is that the antibodies that are produced against this nasty bacteria by the name of Campylobacter jejuni, they begin to cross-react with myelin. You all know that myelin is like a insulation which is present over our nervous system, across our neurons and across the nerves which are present in our body. I mean, myelin is present everywhere in the CNS as well as in the PNS. And most of the time, the antibodies which are present in this condition are cross-reacting with myelin in the peripheral nervous system, not in the central nervous system. Because in the later part of the discussion today, I will teach you a topic where there is damage to myelin in the central nervous system. That disease is called as multiple sclerosis. In multiple sclerosis, the demyelination occurs in the brain. But at this moment, the topic that I'm teaching you, the demyelination will not be occurring in the brain. It will be occurring in the nerve roots which are coming out of the spinal cord. It will be occurring in the peripheral nerves that are present in our body. Peripheral nerves would be like radial nerve, ulnar nerve, femoral nerve, common femoral nerve. So the bad news today is that antibodies are attacking self. Because antibodies are attacking self, that is the reason why, from the pathology perspective, this topic of Guillain-Barré syndrome, when you will read in Saunders, is written as type 2 hypersensitivity reaction. Type 2 hypersensitivity means that there is antibodies against self. There is an autoimmunity that is developing in the patient. The first point to be remembered for this topic is the bug, the nasty bug responsible for this condition, Campylobacter jejuni. Point number two to be remembered for this condition is type 2 hypersensitivity reaction, which means antibodies start attacking self, nerve roots, and peripheral nerves. And these antibodies will obviously develop early, but the manifestations of demyelination will not occur immediately. The manifestations of demyelination will occur after a window period of 2 weeks. Like suppose this patient had food poisoning 15 days ago. This patient had suffered from food poisoning 15 days ago. Today, when he will come to my clinic, the complaints of this patient will be, Doctor, I woke up in the morning, there was no power in my legs. I said, what, are you serious? He says, yeah, sir, I feel as if there's no power in my legs. This guy is a non-medico. He does not understand medical science. So he's telling me that maybe I slept in some wrong position. So some nerve in my legs got compressed. And due to compression of that nerve, at the moment, I'm not having any power in my legs. So this patient, when he woke up in the morning, there was weakness in the legs, which for us as medical personnel, for us as nursing officers, is flaccid. Flaccid means decrease in the tone of the muscles, and there is a flaccid paraplegia. Like this particular individual, he's a young guy. His wife is crying in front of you. His wife is telling you, yeah, last night we went for a marriage party, and both husband and wife are dancing in the marriage party. After dancing, they drove the car back. So husband drove the car. You see, when you have to drive the car, you have to press on the brakes, accelerator, clutch, etc. So she says my husband could drive the car perfectly. I mean, he was perfectly okay when he went to sleep last night. But today morning when he woke up, he was having weakness in his legs. So he was having difficulty in, let me say, normal person will get up, so person has to go to the washroom now. So when person was trying to go to the washroom, he was having a lot of difficulty in walking. So he was trying to take support of the wall or some object and was trying to walk. But ultimately, when he came back from the washroom, he fell down. So his wife thought that accidentally the person had fallen down, but she realized that he is not able to stand up on his own. See, sir, if you go to washroom, if the floor is wet, you might trip and fall. But a normal person, if you fall, will wake up, will be able to get up, no, because your muscles in the thighs, the muscles in your hip joint, knee joint are functioning properly. In this patient, there is a development of flaccid paraplegia. Paraplegia means paralysis of both the legs that is occurring. And obviously, like non-medical people, they will not understand the word paraplegia. So the words that might be written in the book or MCQ can be like rubbery legs. What I mean by rubbery legs is like wobbly legs, like you get weakness in your legs. So you just can't stand and you are like try to stand with support. The initial presentation of this condition will occur after neurological presentation will occur after 2 weeks of onset of food poisoning, and the person will present with flaccid paraplegia or for development of rubbery legs. That's the initial presentation that you see in this condition, and then the paralysis in this patient will continue to go upwards. What I mean by going upwards is, if you can just give me a second, what will happen in this individual is that the paralysis will tend to move like, it will start from the legs, then it will go to the trunk, then it will go to the arms, then it will go to the face of the patient. So the paralysis in this patient, like it shows a ascending progression. So I hope, yeah, it's back. Okay, fine. All eyes on the board, please. Give me like 15 seconds of your black period on the board. What I'm saying is that in Guillain-Barré syndrome paralysis, where does it start from? It will first start in the muscles around the ankle joint. Then it will involve the muscles around the knee joint of the patient. Then it will involve the muscles around the hip joint of the patient. So the paralysis will start from bottom upwards, and that is where the word used is ascending. The amount of paralysis in the left leg will be equal to the amount of paralysis in the right leg. So that's why Sanders will say the word symmetrical. So I'll just write that word here before you at the moment. The paralysis in this condition starts from bottom and starts going upwards. It starts from the feet, that is from the muscles around the ankle joint, knee joint, hip joint, then involve the truncal muscles of this patient. So maybe by the time the ambulance, like this person's wife, she called an ambulance, she does not know how to drive the car. So when the ambulance has reached the hospital, she's saying that he is not able to even sit properly in a chair. Like if you and me have to sit, our truncal muscles have to be in proper tone. If our truncal muscles will lose power, then you will tend to slide towards one side. So when they try to, like maybe in the ambulance, he was able to lie down, or he was able to even, like normally if you're lying down, you can get up by yourself, no, because your truncal muscles are normal. If your truncal muscles will become paralyzed, you can't even get up. So in this condition, there would be a ascending symmetrical. The amount of paralysis in the left leg will be always equal to the amount of paralysis in the right leg. And the technical term in this condition would be always written as, this is one of the key words. This is like the buzzword in the MCQ. Ascending symmetrical flaccid paralysis is one of the key words that if you ever read in your career, whenever you read this particular phrase, ascending symmetrical flaccid paralysis, the term that should always click in your mind is that the question is on the topic of GBS, the Guillain-Barré syndrome. That's the first topic that I'm explaining to you. And in this patient, now the truncal muscle paralysis has started, and no big deal, by today evening, even the arms will become paralyzed. This particular individual will not be able to use his arms also. Like normally when you are sick, you will lie in your bed, you will just fiddle around with your mobile phone, but now he will lose power in his hands also. So he can't grab the mobile phone in his hands. He cannot do any task with his hands. There would be a development of quadriplegia. Quadriplegia, as you all understand, means paralysis of both legs as well as arms of the patient. Now, paralysis of arms is bad prognosis. Why paralysis of arms is an important nursing assessment finding is that if biceps will become paralyzed, you can look at me for a second. If biceps is paralyzed, biceps root value is C5, and C5 shares a nerve root with the phrenic nerve. Phrenic nerve root value is C3, C4, C5. So in this condition, if demyelination occurs in the nerve roots coming at the level of the spinal cord, C3, C4, C5, then phrenic nerve will become paralyzed. And if phrenic nerve will not be paralyzed, diaphragmatic paralysis will occur. The bad news in this condition is that this person might require ventilatory support. This is what happened in Pune, that large number of people had actually consumed chicken from a cloud kitchen, like we all nowadays order from Swiggy and Zomato. So this cloud kitchen was basically making chicken. The point was they were using tap water for cooking. Tap water in India will be contaminated. Dirty water was being used to make the chicken, and the chicken was lots of time, like 10-minute delivery, 15-minute delivery. So we think food is fresh. Actually, food is not fresh. It may be made one day ago. Then they will freeze the food, reheat the food, and give it to you and me. Lots of time we order that 10-minute delivery. We think it is freshly made food, sir. It is obviously not freshly made food. They make the food, they freeze it. And then the reheating, send it, and reheating non-veg item in a hot Indian summer is again a disaster, because when you reheat it, the bacterial germination will again increase, and it will result in release of toxins, which will result in this kind of a manifestation. So unfortunately in Pune, what happened last year was that large number of people had required ventilatory support, and in government hospital, limited amount of ventilators are available. So few people who did not get the ventilator, their relatives started misbehaving with doctors and nurses. They broke up. In fact, they beat up doctors and nurses on duty. If you saw that video, they were pulling hair of that lady doctor and nurse. She was there, no? Like there was a doctor, lady doctor on duty, and the nurse was also came because there was a confrontation. So they pulled the hair of the lady doctor. Can you beat that? I mean, the criminal mindset in India, that they pulled hair of the lady doctor, and the nurse who was assisted, like she was trying to protect, no? So after all, like we are like working as a team, and people are misbehaving. And you would be shocked to know that some people went in the ICU and there was one ventilator that was faulty. They broke that ventilator. Crazy people in India. That could have been repaired. maybe in 1 or 2 days, and maybe would have been used to save somebody people's life, right? A bit crazy people in India, they beat up doctors and nurses, and then on the same day in the evening, health minister walked in. When health minister, that uneducated health minister who's supposed to be taking care of everybody and provide ventilator, when that minister came, no, everybody was touching his feet. Power, no, gunman, blue lights, everything, right? I mean, the guy who's actually responsible. See, you and me will not buy ventilators to take care of the patient. No, you give us ventilator, we will save the patient. I am not going to get a, you and me are not going to buy purchase a ventilator from the market and give it to somebody. So crazy things happen in India, and you know, treatment of this condition is horribly expensive. The drug of choice of this condition is intravenous immunoglobulins. It's 5 lakh rupees, sir. And one day ventilator care anywhere in India is 1 lakh rupees hospital bed. So usually in this condition, about 10 days of ventilator care is required. Imagine 1 lakh rupees per ICU bed, 5 lakhs per medicine. Minimum is 15 lakh rupees. So people who had money, 15 lakhs is not a small amount, sir. If you are belonging to a middle class, right, it's not easy to generate 15 lakh rupees immediately, right? UPI also has a maximum limit of 99,000 only. You go to any corporate hospital in Bengaluru, when they ask you 15 lakh rupees, you'll be shocked, man. What is happening, right? How do you arrange that money? You might be having a lot of money in your family, lot of money, land, and everything, and gold, but you just can't go and send land, your land like that or anything like that. So, like, what I'm trying to tell you is that a lot of people, unfortunately, because they did not have the resources, they died. They died, sir. And like, you know, the people were touching feet of that minister. So it's a crazy thing happening. But anyway, we will study regarding how a doctor or nurse will assess the diaphragmatic paralysis component. The most common cause of death in Guillain-Barré syndrome. Overall, the most common cause of death in Guillain-Barré syndrome happens to be diaphragmatic paralysis. The question for you guys is, how would you assess whether patient's diaphragm is getting involved or not? So obviously, the nurse will monitor one thing, that is respiratory rate. You can understand that if a person is having diaphragmatic paralysis, then the respiratory rate will become lesser. You will also notice not only the rate, but the depth of breathing, because you see, you and me can take a deep breath, but here the depth of breathing will also become less. So rate will also become less. The depth will also become less. You will also check the oxygen saturation. The saturation will become also relatively less. And one of the very important parameters will be what we call as single breath count. Single breath count would mean like I'll do it myself. I will count like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So you and me can count up to 15. You will ask the nurse will ask the patient to count up to 15 in local language, whatever, like 1, 2, 3, 4 in Hindi, or 1, 2, 3, 4, 5, 6 up to 15 in English. So single breath count. Single breath count implies that ask the patient to count up to 15. If you and me, diaphragm is working properly and you and me are not breathless, then you and me can count easily up to 15. But in this particular case, patient will not be able to. You can put it on yourself. No, if your diaphragm is not working properly, you will be out of breath. And if you're out of breath, then the ability to count will dramatically be reduced. So single breath count is an important parameter apart from the parameters that I explained to you, which will help a nursing officer determine that there is a diaphragmatic paralysis that is developing. And I would like to give a parallel example here. Like suppose a patient came to the hospital after a snake bite. You are all aware that cobra bite, most of the time in India, it's a cobra bite. Cobra bite will also result in diaphragmatic paralysis. So even in the MCQ of snake bite, if he will say to you that how will the nurse be, or what parameters the nurse will assess to evaluate for possibility of diaphragmatic paralysis, the parameters will remain the same only: respiratory rate, depth of breathing, oxygen saturation, single breath count. And obviously it's not available in India, the last point that I'm saying, but we have a portable spirometer, and by spirometry we can do a test by the name of FEV1 FVC ratio, and we can evaluate that also. So spirometry, I can say portable spirometry. Normally, like, you know, there's a separate spirometry room in the hospital where asthmatic and COPD patients will go, but sometimes we have portable spirometry devices in which we can ask the patient to breathe out, and in this patient's portable spirometry will be revealing less ability to breathe out, like FEV1 or forced expiratory volume in 1 second will be reduced in the patient. Even if I don't have that portable spirometry, it really does not matter. But the parameters I want you to remember is diaphragmatic paralysis is a unfortunate complication that could be developing in this condition that I've currently explained to you. And well, the bad news is the disease will not stop only here. The disease will not stop only here. This is just the starting of the disorder. You will also be having involvement of the neck muscles in this condition. So you and me can sit the whole day. Our neck muscles are super strong. But in this condition, you will notice neck floppiness will also be a nursing assessment finding. That neck floppiness means that neck will be sagging like this. You know, you and me, like at the end of the day, all of us get tired. So you move your neck like this, because your neck is hurting because you're sitting in the class all the day. But it's not that your neck would be dropping, right? Here, the neck dropping would be happening, neck floppiness would be developing in a patient. And then the paralysis will involve the facial nerve. If they ask you what is the most common cranial nerve involved in Guillain-Barré syndrome, if they ask you what is the most common cranial nerve involved in Guillain-Barré syndrome, then it is the seventh cranial nerve that would be involved. And mind my words, it is not Bell's palsy. Bell's palsy is the unilateral seventh nerve paralysis. This would be a bilateral seventh nerve paralysis that would be developing in a patient, which in a multiple choice question, to make it sound sophisticated as NORCET is supposed to be, they might use the word facial diplegia. Facial diplegia would mean paralysis of both the facial nerves. There are two medical disorders in your career where you will always read facial diplegia. One is the topic of interest, Guillain-Barré syndrome, and second is a medical disorder that we will study in rheumatology, sarcoidosis. Sarcoidosis and Guillain-Barré syndrome are two medical disorders where you read regarding bilateral seventh nerve paralysis that is developing in a patient. Do not confuse this with Bell's palsy. I will explain Bell's palsy separately before you. Bell's palsy is a unilateral. It is one-sided seventh nerve paralysis. Can you tell me the most important cause of can you tell me the most important cause of Bell's palsy? Why does it occur? Somebody's half face became paralyzed. I will teach you how to identify it, but like what is the usual most common cause of half face? But not, we're not discussing stroke, right? We're discussing normally facial paralysis occurs in stroke. One of the leading causes of Bell's palsy happens to be infection. In fact, I would also like to mention regarding one more important cause which occurs with chickenpox. I think all of you have at least read the name Ramsay-Hunt. Ramsay-Hunt syndrome. That Ramsay-Hunt syndrome is what you see with chickenpox, that is varicella zoster. So most of the time it could be infection with any virus, any routine virus, like swine flu is occurring at the moment. So swine flu can contribute to Ramsay-Hunt syndrome that's seen with varicella zoster. Varicella zoster is the other name for chickenpox. So what I just wanted to bring to your attention is that Bell's palsy is a condition which can occur due to infection. And for Bell's palsy, I'm mentioning here only, though I'll discuss separately, the drug of choice is steroids. Can you tell me steroids should be started within how much time in Bell's palsy? 72 hours. If we start steroids, it will reduce the swelling of the nerve and therefore the recovery chances will be relatively more. Why is it being taught to you at the moment steroids? Because in Guillain-Barré syndrome, we don't use steroids. In Guillain-Barré syndrome, we give intravenous immunoglobulins, but in the MCQ, he will deliberately write, select the wrong statement in Guillain-Barré syndrome. Just answer for me. In Guillain-Barré syndrome, what do you give? Do you give steroids or do you give intravenous immunoglobulins? Yes, intravenous immunoglobulins are antibodies against antibodies. You see, after infection, there were antibodies forming, bad guys that were being formed. So antibody against antibody is what is called as intravenous immunoglobulin that is used. But anyway, as a general statement, what I wanted to say was Bell's palsy happens to be a unilateral cause of facial paralysis, whereas in Guillain-Barré syndrome, it will be a bilateral seventh nerve paralysis. So a paralysis starts from the feet, then involves the muscles of the knee joint, then of the hip joint, then the truncal muscles, the arm muscles, the neck muscles, and the facial muscles. That is why the key word in the question was ascending, symmetrical, flaccid, because it is lower motor neuron lesion. It is ascending, symmetrical, flaccid paralysis, with the number one reason of death in the patient being diaphragmatic paralysis. So the highlight of this condition is this condition will be causing motor involvement. But does Guillain-Barré syndrome have sensory involvement? The answer is yes, because nerves have motor component and sensory component both. No? If I say, can you feel the ground under the sole of your foot? You can feel the ground under the sole of your foot. Your nerves are having sensory component. If I say, can you move your foot? You can move your foot also. If I say, can you feel the ground under your foot? You can feel the ground under the foot. So nerves have a mixed component, that is motor as well as sensory. So sensory components will also be seen. What will be the sensory complaints given in the question? It will say tingling sensation in the extremities. That would be like paresthesia. So don't be surprised if he talks about sensory complaints in a patient. That could be like paresthesias or tingling sensation in the extremities could also be experienced by patients of Guillain-Barré syndrome. So motor involvement will also be there and sensory involvement will also be there. Apart from the motor and sensory involvement, there can be autonomic involvement also, because nerves have a motor component, nerves have a sensory component, and nerves have a autonomic involvement as well. What I mean by autonomic involvement is that if you look at our spinal cord, fibers of our spinal cord from T1 to T4, fibers of our spinal cord from T1 to T4, they provide sympathomimetic stimulation to our heart. Fibers from T1 to T4, they provide sympathomimetic stimulation to your heart. For example, I say to you, okay guys, can you do some sit-ups, some push-ups? If you will do some sit-up, push-ups, your heart rate will increase, no? When your heart rate will increase, that is due to sympathomimetic stimulation. There would be electrical current flowing through your T1 to T4 that will stimulate your heart, and your heart will start beating faster. Now in our heart, there is a balance. The balance is maintained by a parasympathomimetic system. The parasympathomimetic system operates on vagus nerve. So in our body, there is a balance between sympathomimetic and parasympathomimetic system. That is, our heart rate remains between 60 to 100. That's the normal range. What happens in Guillain-Barré syndrome is, the bad news is antibodies cause damage to these sympathomimetic fibers. So I'm putting a line over this to say that sympathomimetic fibers have been damaged. If sympathomimetic fibers are damaged, then you can notice that the balance between the sympathomimetic and parasympathomimetic will be lost. If the balance between sympathomimetic and parasympathomimetic will be lost, now vagus will be acting alone on the heart. So please look at the board and let me know what will happen to the patient if there is demyelination of T1 to T4 nerve roots. If T1 to T4 is gone, sympathomimetic activity is gone. If sympathomimetic is gone, only parasympathomimetic activity of vagus is there. So will the person suffer from tachycardia, or will there be a bradycardia? Bradycardia. The bad news is that there could be a development of bradycardia in these patients as well. And you can understand, because of bradycardia, the BP of this patient might begin to fall. This presentation is itself an MCQ, not only from GBS perspective, but a generalized MCQ, neurogenic shock. Guys, shock always has tachycardia. You would have done a MCQ of your exam. Which shock will be having bradycardia? The shock that will be having bradycardia is right in front of you. This is not only important from GBS perspective, but as a MCQ on its own. All shocks by default have tachycardia. The only shock that will be having bradycardia is neurogenic shock. Let me explain point number 7 once again to you. In our heart, we have balance between sympatho and parasympathomimetic activity. In GBS, any of the two can be affected. Suppose, God forbid, if vagus nerve was demyelinated, if vagus nerve was damaged, then there would be a tachycardia. But usually what we see is the sympathomimetic system getting affected. If sympathomimetic is affected, then vagus will be unaffected, and that will cause the heart rate to slow down, and bradycardia manifestation will occur. To cut the long story short, at least remember the fact that in GBS, you can have motor involvement, you can have sensory involvement, you can have a autonomic involvement occurring as well. And therefore, to make the question look sophisticated, you will notice that in Saunders, this particular terminology is given. I will write down the terminology as acute, inflammatory. You see, everything was about antibodies and inflammation, acute, inflammatory, demyelinating, polyneuropathy. In some MCQs of Guillain-Barré syndrome, they will not write the word Guillain-Barré syndrome. In some MCQs of Guillain-Barré syndrome, they will not write the word Guillain-Barré syndrome. They will say acute inflammatory because antibodies were there. Demyelinating polyneuropathy, AIDP, is a terminology that I want you to be very comfortable with. Whether in your exam he writes the word GBS or whether he writes the word AIDP, both mean the same. Now, because of the fact that my patient could be having crashing of his blood pressure, patient could be having diaphragmatic paralysis, I need to do a workup. So let us now look at what are the tests that would be done for diagnosis of this medical condition. The most important test that would be done for diagnosis of this condition is called as NCV. What do you mean by NCV? NCV stands for Nerve Conduction Velocity Test. And I think all of you know that myelin is like a covering or insulation over the nerves. So nerve conduction velocity in this particular condition will be reduced. To make it sound sophisticated, he may not write the word nerve conduction velocity is reduced. He may write the word increased latency. He's just playing with English, guys. Don't worry. Whether I say the word nerve conduction velocity is reduced or I say the word increased latency, both basically mean the same. He will say all are correct about GBS except. So whether I say reduced nerve conduction velocity or I say the word increased latency, it basically means the same, that nerves are not working. Then to waste your time in the MCQ, he will give you a lumbar puncture report. Now, this is where the MCQ will turn very interesting, that he will talk about a lumbar puncture report. So I will teach you about the procedure of lumbar puncture also, which we routinely do in meningitis. And he will give you a report of the cerebrospinal fluid. In this report, we will notice that cells of the CSF will be normal. You will notice that the sugar report, I will teach you all these normal values also, but at the moment, just hear me out. The cells will be normal, the sugar will be normal, the pressure will be normal, the color will be normal. When you will be checking the report, you will be saying to yourself, what the hell, man? Everything is normal, normal. Why the hell is he giving this in the question? What he will mention is CSF protein. You are all aware as nursing students that when you have antibodies, gamma globulin, it is protein only. Antibodies, gamma globulin, it is protein only. Only proteins will be elevated. Only proteins in the cerebrospinal fluid will be elevated. Everything else will be normal. This particular description that I gave you is called as albumino cytological dissociation. Albuminocytological dissociation. I'll just write the whole thing in capital because this is again a very fancy terminology that the examiner would like to mention. Albuminocytological dissociation. What it means is that the cells are normal, everything is normal. The only thing that is elevated is, can you check out from the board and tell me what is elevated here? Proteins in the CSF, because antibodies are there. So albuminocytological dissociation will be the lumbar puncture report in this condition. To cut the long story short, because we are very near the exam, the query of most students is, sir, how do you expect us to remember all this? So I have a mnemonic for you guys. The mnemonic is 4 letters. Even if you have not noted all the 4 points, now whatever I am saying, you must note down, because this 4-letter mnemonic will do the job for you. That is, FAME is a mnemonic. It is a shortcut which helps you remember the data. Alphabet F will stand for flaccidity. It would be a flaccid paralysis developing in this patient is the first prerequisite that should be given in the case-based scenario that they love to give in NORCET. Alphabet A will stand for areflexia. Reflexes will be lost in the patient. The reason why reflexes are lost is nerves are demyelinated, so the firing of the reflexes will not occur. Alphabet A is also for this fancy terminology, albumino cytological dissociation. Albumino cytological dissociation, what it means is the whole report is normal except for proteins. Alphabet M is for the monophasic course in this condition. What I mean by monophasic course is that the paralysis in this condition can be so fast that the person might require ventilator support in 12 hours. Like this patient woke up in the morning today, he was saying, I don't have any power in my legs. By afternoon, the paralysis will spread to the trunk, then to the arms. And by evening, the guy is on a ventilator. His wife is crying in front of you, sir. Yesterday, we went to a party, we were dancing, we were enjoying. And today the guy is on a ventilator. Imagine in 12 hours, the whole life of this family is upside down. I mean, yesterday they were enjoying their life. They were not even in their wildest dreams. They would have thought that, that my husband or my loved person might be requiring a ventilator support. And now this person is having a ventilator requirement. But sometimes in this condition, the possibility is that the progression of the disease can be slow. Like in the first week, the paralysis can only be in the legs. In the second week, the paralysis will be in the trunk. In the third week, the paralysis will be the arms. And in the fourth week, the paralysis can be involving the diaphragm. So in patients of Guillain-Barré syndrome, you can be having an ultra fast progression, or in some questions, the progression can be over 28 days. What I mean by 28 days is, let's do this again. First week, only paralysis in legs. Second week, the paralysis in the trunk. Third week, the paralysis in the arms. And fourth week, the guy is having a ventilator requirement. So you can see the contrast there, which we call as a monophasic course. And alphabet E is for the electrodiagnostic tests that I was teaching you. Electrodiagnostic testing that we are doing in this case. The electrodiagnostic testing that we're doing in this case is nerve conduction velocity testing, which is the investigational choice of this condition. In nerve conduction velocity, obviously the conduction velocity will be slow because the nerves are demyelinated. FAME is a mnemonic by which you can remember the manifestations of this condition. I have already explained to you that the most important cause of death in this patient is diaphragmatic involvement. And for diaphragm involvement, I again don't need to write counting the respiratory rate. That is obviously very, very simple. But I did talk about that statement of single breath count. That single breath count is an important nursing assessment finding where you will ask the patient to count as fast as he or she can. And normally we ask the patient to count from 1 to 15, and this person will not be able to do this task. Diaphragmatic paralysis, the parameter that we use for evaluation is called as single breath count. This is the minimum that I expect you to know for this topic right now, right here from the nursing assessment finding. And well, what is the treatment? You will have to give the treatment on the advice of the physician. Well, what will be the advice of the physician? The advice would be to start the patient on IVIG, that is antibodies against antibodies, that is intravenous immunoglobulins would be given to the patient. These intravenous immunoglobulins will be needed to be given to these patients as injections twice a day for 7 days. There is one more approach available for management of this condition, which is available only at AIIMS Delhi, and you would have read about it, that is called as plasmapheresis. We can change the plasma of the patient. We can change the plasma of the patient because the plasma is containing harmful antibodies. So if you change the plasma, the harmful antibodies will be removed from circulation, the same antibodies that were causing paralysis. We can use any of the two approaches. Between the two, if they ask you to select one, then if he says what is the treatment of choice, the answer is intravenous immunoglobulins. Drug of choice is also intravenous immunoglobulins. Most students are under impression that drug of choice is IVIG and treatment of choice is plasmapheresis. No. The drug of choice and treatment of choice is same. Most students think like this, that drug of choice is IVIG, treatment of choice is plasmapheresis. No, because plasmapheresis will require expensive setup. Now you need a special machine, you need a donor, and obviously all of that is expensive. So what we recommend is intravenous immunoglobulins for these patients, IVIG. Along with this, obviously, ventilator support would be required for this patient. Ventilator support would mean that we will have to intubate the patient and then keep him on a ventilator for like maybe as long as required, maybe sometimes maybe 10 days, maybe something like 14 days as well. All of you as nurses are aware that we should not do intubation more than 7 days. All of you are aware that intubation more than 7 days will result in a complication called as tracheal stenosis. So here your nursing responsibility will also involve that you will have to assist in providing a tracheostomy kit, because tracheostomy is ideally recommended in these patients. Tracheostomy is recommended because we want to avoid prolonged intubation. What is the definition of prolonged intubation? Intubation for more than 7 days. Definition of prolonged intubation is intubation more than 7 days. If unfortunately you have to keep somebody intubated for more than 7 days, you will end up with a complication where because of the tube will irritate the trachea, and when you will successfully extubate the patient, there will be a development of tracheal stenosis. If you know in advance that patient will take a long time to recover, we will counsel the relatives in advance only. That, sir, we need permission, and family members is shocked. This guy's wife is, what are you talking? You will make a hole in the neck. You will put a tube from here. You and me can understand it will be shorter tube, less dead space, easier control of the airway. But for a non-medical person, it's gonna be shock. Like, what the hell are you talking? You will put a hole in the neck. From here, you will put a tube, and like how inhuman you are. So they'll scream at you, they'll be angry at you, and you need to keep your calm there, right? Because it's not a very small decision. And lots of times they'll say, no, I will ask senior people in the family. Then, and senior people in the family are less educated. They'll not have that, wisdom to do that. So it might be a joke for you and me, but if it's on my family, and if it's my dad who's having a hole in the trachea, and from there the doctor will put in a tube, I'll be in a shock, right? So we need to maintain compassion there, empathy, right? We don't need to be sympathetic. We need to be empathetic and emphasize to them that it will be in the best interest of the patient. Just generally speaking, to all of you, a question from my side since I've been doing the talking. Usually in adult male, what number endotracheal tube do you put? 8 mm internal diameter. Adult female would be about 7.5 millimeter internal diameter tube. So will we put an endotracheal tube in this patient? Intubation is an easy process that will never cause an issue. But then the point at the same time is intubation more than 7 days, the risk of tracheal stenosis is very much there. Because of the risk of tracheal stenosis, that is why tracheostomy would be recommended in these patients if we are anticipating a prolonged recovery in this patient. Plus, obviously, because the patient will be bedridden, so your job as a nursing officer will be obviously the care of the back. Any bedridden patient, care of the back, care of the bowel, and care of the bladder. The three B's of nursing care. The three B's of nursing care, care of the back. In any bedridden patient, care of the back, care of the bowel and bladder is important because you have to frequently turn the patient. No, you have to do turning of the patient every 2 hours because there is a risk of bed sore. There could be a decubitus ulcer or bed sore developing. We would not like to keep the patient on a normal mattress, no, because if you keep the patient on a normal mattress, then the risk of development of bed sore will be relatively more. So we might be using a air mattress or like a water bed, which will fit the contour, right? Routine hospital mattresses in government hospital are so hard that bed sore will anyway develop. Decubitus ulcer or bed sore can occur at multiple sites. The sites can be obviously in the form of sacrum. It can be over the ischial spines. The bed sore can be developing on the trochanter because when you will turn the patient on one side, that is where the bed sore can be developing. You can have bed sore developing on the heel of the foot because if somebody is lying in supine position all the time on the heel, it can occur on the occiput, it can occur. So our job will be to prevent the bed sores from occurring. And anyway, you can comment as 1, 2, 3, 4. Which of these is the most common site? No. That's the commonest mistake that we do now because we don't keep patients in supine position. We keep them in a slightly head and elevated position to reduce the risk of aspiration. The most common site of bed sore, guys, the most common site of bed sore in government hospital is obviously sacrum because we keep the patients in supine position. But usually we keep the patient in a slight head elevated. The way you're sitting on a chair at the moment, the weight of your body is falling on your ischial spine. Na? This was again a question of your exam that what is the most common site of a bed sore? The most common site of bed sore is not the sacrum. It is because of the poor care that we give that the site is the sacrum. Otherwise, it is going to be ischial spine, which is the most common site. I repeat this statement, the most common site. If he specifically says, overall, what is the most common site? Where we have is a development of decubitus ulcer, it is the ischial spines, and obviously bed sores can occur at any point of time. But if it's occurring on the sacrum, that is our negligence. Purely in our hospitals, what happens is over the sacrum because patient was kept totally supine, so it's a slightly head and elevation to minimize the risk of aspiration because not everybody requires an intubation also, no. But patient can aspirate at any point of time. So, and it is don't be under impression that it is only the seventh nerve that can get involved. It can be the remaining cranial nerves also, no? Like I can introduce a term by the name of bulbar palsy. What I mean by bulbar palsy is that cranial nerves that originate from the base of the brain can get involved. Like the patient may be having ninth nerve paralysis, 10th nerve paralysis, ninth and 10th nerves. They're super important for gag reflex and cuff reflex. If you ever read the word bulbar palsy, then what is the term that should always come in your mind is ninth nerve involvement, 10th nerve involvement, 12th nerve involvement. Because in Guillain-Barré syndrome, antibodies can attack seventh nerve, they can attack the ninth also, and the 10th also, and the 12th also. If the ninth nerve will be affected, you see, we have important reflexes. Like, for example, if you are brushing in the morning, if accidentally your toothbrush will hit the back of your throat, you feel a gag, na? I said you're cleaning your tongue in the morning. If accidentally your toothbrush will hit the back of your throat, you will get a gag. Similarly, it may so happen that you're drinking water. You are drinking water, you are feeling very lazy, you are drinking water in lying down position. You don't feel even feeling like getting up, you're lying down and trying to drink water. If even a little drop of water will go towards your trachea, you will cough so much that literally water will come from your eyes. No, it might have happened sometime that you're drinking water, your brother or sister made you laugh and water went towards the trachea and you coughed so much. That literally tears will be coming from your eyes. So we all have is what is called as a cuff reflex. So all of these reflexes are mediated by, like, the root value of the gag reflex is ninth and the 10th nerve. If they say what is the root value of the cuff reflex, it is 10th and 10th, afferent and efferent. Afferent sensation in the throat is also vagus nerve, and the cuffing reflex is the efferent contraction of the muscles is also going to be the 10th nerve. Guys, it's not sacrum. It is the ischial spines, which is the common side. These are common reflexes. These common reflexes will be lost in the patient. If you ever read the word bulbar palsy, what will happen in the patient will be that now if you give even one drop of water, the water will go in the trachea. So patient can't drink. If you ever read the word can't drink, can't eat because 12th nerve is hypoglossal nerve that controls the tongue. If your tongue is paralyzed, you can't eat, no, because the tongue is also playing a role with respect to swallowing component. So if you talk about can't eat, can't drink, can't talk, because after all, talking is again a function that's related to vocal cords, right? Or can't speak, in fact, instead of like you say, can't eat, can't drink, can't speak. Things that we don't even think about eating, drinking, speaking, because vocal cords of yours and mine are powered by the vagus nerve. Vocal cords of yours and mine are powered by the vagus nerve. If vagus nerve will become demyelinated, we will not be able to speak. So the learning point for you guys as nursing officers is that if you ever read in a neuro case that patient cannot eat, can't drink, can't speak, it means which nerves are getting involved? 9, 10th, and 12th. And the technical term for that is bulbar palsy. The learning point for you guys is can't eat, can't drink, can't speak basically means 9, 10th, and 12th is getting involved. That is bulbar palsy. So in these patients, obviously patients will be kept nil per urli, no? And when you keep somebody nil per urli, obviously in a hot Indian summer, we don't have air conditioning in the wards now. So lips of the patient will become dry. So obviously in fawn, they would have taught you that you can apply ice cubes over the lips of the patient. You can make the patient, apply some ice you can put some Vaseline on the lips to prevent the cracking of the lips. And you can apply some ice also because otherwise the mouth will become dry. But obviously you are not allowed to make the patient swallow anything because of the huge risk of aspiration. So in GBS, it is not only possible that 7th nerve is getting involved, guys. It can be 9th, 10th, and the 12th nerves that could also be involved in a patient. So make mention of the fact 7th can be involved, 9th, 10th, 12th can be involved. If you ever read these terms, it means bulbar palsy is occurring. And that's again a bad prognosis for this condition. So the topic that I've explained is Guillain-Barré syndrome. And the four, I would say, 4 points for this particular topic would be: one is how to identify GBS in a question, ascending symmetrical flaccid paralysis. Point number 2 to be remembered: single breath count is used to assess diaphragmatic power in this patient. Then is obviously the C's, that is care of the back, care of the bowel, and care of the bladder in the patient. Because in GBS, ultimately, like, we need to prevent any kind of urine retention. We want to prevent fecal impaction in a patient. You might have to give enema sometimes, because you see, if somebody will keep on lying in the bed, high risk of fecal. Even if normal person is not doing physical activity, constipation will occur. No? Like normally, if you keep on studying whole day and you keep on sitting at one place, constipation will occur. Anal fissure will occur in a patient. So you might have to give enemas in these patients also. You might have to put a Foley's catheter in these patients as well in case the bladder gets involved. And obviously, our primary objective is to prevent any risk of aspiration and prevent any development of bed sore in this patient. But with good nursing care, after 14 days, usually recovery will occur. After 14 days, I'm not saying the guy will start walking. Obviously, it will require a lot of rehabilitation. It will require a lot of willpower on the part of the patient and the doctor and nursing staff to motivate this guy to walk first with the help of a walker, then with the help of a stick. And finally, the patient will be back on his feet. So in GBS, we do have recovery, but the recovery part is obviously a long run process. So one more point I would like to just write towards the end is physical rehabilitation is important. What I mean by physical rehabilitation is that we need to make the patient be able to walk again. Like a little baby is taught not to walk, like this adult person will be learning to walk again. So physical rehabilitation would be required, for which various aids might be required. The aids are in the form of a walker, Or it could be because there's paralysis in the leg now. So when the power in the leg will come back when you give intravenous immunoglobulin, physical rehabilitation in the form of walker or stick might be required. Not crutches most of the time. Crutches would usually not required, but walker and stick would at least be required so that he can maintain his balance. No, I'm not saying like somebody has a spinal cord injury, then he might require crutches for walking, spinal cord injury. But here it was inflammation that is occurring in the spinal cord. It's not a permanent damage. So GBS is one medical disorder which has a recovery possible. Normally neurology we don't have recovery, but here recovery is very much possible. So that was one of the opening topics. It is one of the opening topics that I've explained to you at the moment, that is called as GBS, Guillain-Barré syndrome. And now I'll be in a better position to explain to you a couple of more very particular disorders at the moment. So since I was talking about lumbar puncture, it also makes sense to talk about another topic, that is the second one for today that I'll cover, that is meningitis and encephalitis. So I will teach you organisms responsible for it, and I will also teach you what are the keywords in the question, what are those buzzwords that will tell you that this is a case of meningitis or encephalitis. But first, let's talk about organisms. If he says which bacteria, because most of the time it is bacterial meningitis. So most of the time it is it can be viral also, it can be fungal also. So I'll teach you all of them. But first and foremost is you should be aware that which is the bacteria which is responsible for causing meningitis. Then in adult population, any guesses? Streptococcus pneumoniae. The overall number one cause of bacterial meningitis in adult population is Streptococcus pneumoniae. Can you tell me for child, please? The answer is still the same, Streptococcus pneumoniae. Neisseria meningitis is also an organism in both adults and children, but it is not the most common one. The most common one is still in both populations, Streptococcus pneumoniae. Yes, in children, one more will be there, that is Haemophilus influenzae. But even if you don't know the word Haemophilus influenzae and ICV meningitis chalega, what you should be knowing is Streptococcus pneumoniae is one of the leading causes of bacterial. The same bacteria that causes pneumonia is also the leading cause of bacterial meningitis in adult and children. And then you can change the question. I hope you had pediatrics, newborn baby. Number one cause of bacterial meningitis in newborn baby is? Your answer is very good. I'm having good answers there. Group B, Streptococcus. So step one for this topic would be to try and remember the bacteria that are responsible for contributing. Don't go for the second organisms. That second organism that I'm telling you is only for the sake of completion, Listeria monocytogenes. So people tend to focus on Listeria. But what you need to remember is adults would be Streptococcus pneumoniae. Child is also Streptococcus pneumoniae. Neonate would be group B, Streptococcus. Now, what will be written in the question that will tell you that this is a case of meningitis? Then there will be a triad. The buzzword in the question will be, if you ever read a question that begins with fever, along with headache, and development of nuchal rigidity. For nuchal rigidity, you can look at me for 5 seconds. Look at me for 5 seconds. You will ask a patient to flex the neck, like you and me can flex the neck so that our chin can touch the chest. But in meningitis, because of irritation of the nerve roots coming out of the spinal cord, there is stiffness of the neck muscles. Therefore, because of the stiffness of the neck muscles, when you will ask the patient to flex the neck, he or she will not be able to do it. So the word is nuchal rigidity. This is the buzzwords. These are the keywords that I want you to remember. Anytime in a question you read fever, headache, nuchal rigidity in a patient, you have to think regarding bacterial meningitis in a patient. But obviously, this thing will not be valid for a newborn baby. Though this is taught in pediatrics, I would like to still mention, how will you pick up meningitis in a newborn baby? The question will say baby is having vacant stare, and then the question will say bulging anterior fontanelle. All of you have studied that there is a opening in the anterior part of, like there's a boggy area in the anterior part of the skull of a newborn baby that is called as anterior fontanelle. So if you read the word bulging anterior fontanelle, AF, it's always in favor of raised ICP in children. Vacant stare, poor feeding, and bulging anterior fontanelle is a feature that is seen for neonatal meningitis. But in adults, it is fever, headache, and nuchal rigidity that would always be given as nursing assessment findings that you need to pick up. Now, in all of these patients, For diagnostic purposes, obviously, we need to prove that there is an infection. And to prove that there is an infection, what we will do in these patients is a lumbar puncture. This lumbar puncture that should always be done should be done as slowly as possible. We should never rush into the procedure. If we will do lumbar puncture very fast, when suddenly the CSF will come out with force, it can even result in death of the patient. So I'm using the word guarded lumbar puncture. By guarded lumbar puncture, it means that when I will do the procedure, I will let the CSF come out drop by drop. We should not be allowing the CSF to gush out very fast, otherwise it will result in brain herniation and the patient can die. It will always be guarded lumbar puncture. In guarded lumbar puncture, the concept is that we don't withdraw the needle from the stellate. There's a stellate, so we don't remove the needle from the stellate immediately. We just gradually withdraw it so that it flows drop by drop and not in the form of a straight gush of CSF. Otherwise, brain herniation can occur. The preferred site for doing a lumbar puncture. The preferred site for doing a lumbar puncture is L3, L4. Preferred site for doing a lumbar puncture happens to be L3, L4. The patient will be in a lateral decubitus position, like you will ask the patient to lie on his side. For performance of lumbar puncture, the patient will be in the lateral decubitus position. That is, patient will be made to lie at the edge of the hospital bed or on the stretcher. And then you will ask the patient to flex his knees so that the knees touch the chest. That is knee chest position. Since you as a nursing officer will be responsible for maintaining the position of the patient, first you will ask the patient to lie at the edge of the hospital bed on his side, lateral decubitus. Then you will say that curl up in a fetal position. What I mean by fetal position is that the knees of the patient should be touching the chest. So knee chest position. Step 1 is lateral decubitus, then is knee chest position. Make the patient lie in a curled up fetal position, that is knee chest position. After which you can place a small pillow below the neck of the patient. If you don't have a pillow, you can take a towel and roll it below the neck for a gentle neck flexion. Don't try to forcibly flex the neck of the patient because it will cause pain, because there's already a nuchal rigidity. So as far as the position of the patient is concerned, there are 3 steps. As far as the position of the patient is concerned, there are 3 steps. The steps would be lateral decubitus, knee chest position, and gentle neck flexion. Any procedure which is invasive is always to be done after taking consent. The consent is always taken by the doctor. Signatures will be taken by the nursing officer, but consent is not to be taken by the nurse. The consent is always taken by the doctor. Your job is to ensure 2 things. One is maintain the position of the patient, and second, papers should be signed by either the patient. If he is not in his senses, then whatever is the nearest loved one, brother, sister, whosoever is available, their signature should be available. Contraindication for lumbar puncture. The most important contraindication for lumbar puncture is raise ICP. If pressure in the brain is more and lumbar puncture is done, brain herniation will occur. This happened unfortunately like couple of months back. I'm not sure whether you read about it. Like, a couple of people go outside India to do MBBS. So one guy, he was a foreign medical graduate. He had gone to Kazakhstan. Almaty was a place, Kazakhstan, to do MBBS. So there he had these features of headache and nuchal rigidity coming up. So they told in that Russian Soviet hospital that we will do your lumbar puncture. A lumbar puncture was being done there, and these Russian hospitals nowadays are not in good condition because Russia is collapsing. So when they did this lumbar puncture, one, they used a very thick needle. Whenever you do lumbar puncture, you are supposed to use as thin a needle as possible. They used a very thick needle, and when they put the needle, they did not gradually withdraw the stellate. They immediately took out the stellate, so there was a gush of CSF, and due to this gush of CSF, this boy, he went into respiratory arrest. Once he went into respiratory arrest, he required intubation. And you can very well understand if somebody stops breathing and then you intubate the patient, then brainstem will be damaged. So this guy was in a foreign country, had gone there to do MBBS. He was a first year medical student, 17 years of age, and he went into cardiorespiratory arrest, and he was then put on a ventilator. Now, because he was on a ventilator, obviously no airlines will fly him back. All airlines, whichever airlines you say, they are not ready to fly. No, you need an air ambulance for that. So luckily, Indian government now has become more responsive. So they flew a private ambulance, right, for this guy. That ambulance charged almost 50-60 lakhs for that airlift, though it's a 3-hour flight only. Indian government paid for it. Earlier, if you are stuck abroad anywhere, no, you keep on tweeting, Indian government will never come to your help. If you are now in any part of the world, no, you send one tweet, Ministry of External Affairs, they will come for you. This is a new thing that is happening in India. Don't leave an Indian abroad alone, right? Indian government earlier never used to, it was the American way, na? Americans, they would leave a fellow American every time. Any American soldier in Afghanistan, Iraq, or anywhere gets sick, they will spend unlimited amount of money and will transport that soldier and will save a life. So at least now it is happening that Indianism, that we are Indians, Hindustan, that thing is coming that we want to save. So anyway, I'm not trying to be political or like what I'm trying to say is that's a good thing that's happening. So they flew a jet and brought him back here, but he died. The learning for you guys and me is that we should never be putting a thick needle whenever we're doing a lumbar puncture. We should never be rushing into the procedure because when we put the needle fast, the gush of CSF will cause a respiratory arrest in an individual. So that's one of the very big contraindication to lumbar puncture. Then the second important contraindication to lumbar puncture is bleeding diathesis. A patient is having a bleeding tendency, like somebody is on warfarin, somebody is on aspirin. Bleeding tendency will cause local bleeding when you put in a needle. Another reason why lumbar puncture may not be done is local site infection, like in India due to poor hygiene. Now it is like, humid, hot. So somebody could be having local pustules on the skin. There could be local infection at L3, L4. If somebody is having a local site infection and if I put a needle through that area, I'll be literally introducing bacteria into the brain of the patient, into the CSF. Local site infection. So three absolute contraindications for performance of lumbar puncture are raised ICP, bleeding tendency, and local site infection. I mean, lumbar puncture should not be done. And therefore, in my mind, after the consent has been taken by me and you have obtained the signatures, I will also run the checklist. Assuming that there is no contraindication to lumbar puncture present in a patient and the patient is in proper position, now what we will do is obviously we will take all aseptic precautions. So he can ask you that what solution can be used to clean the back of the patient so that we can perform lumbar puncture. So we can use chlorhexidine, and when we clean the local area with chlorhexidine, we go in a circumferential fashion, and the routine method of cleaning is you go from inside outside, and whichever site you touched once, you're not supposed to touch it the second time. So we will be cleaning from inside to outside, and then you will be putting drapes also. So there is a lumbar puncture tray available, and your job as a nursing officer is to ensure that tray, maintain that tray, and put on the drapes because now the site will be ready. Once the site will be ready, what we will now do is we will do lumbar puncture in the patient and we will try to use the thinnest possible needle. Usually the number of needle that you are supposed to provide to the physician will be 25 to 27 G needle. Always provide the thinnest possible needle. I think all of you are aware as nurses that the higher the number, thinner will be the needle. It is ultana, the bore of the needle. So 27 G needle will be the one that should be preferably used. The 25 to 20 G needle will be introduced gradually. This 25 to 27 number needle will be introduced gradually, and the physician's job is to be gentle because he will puncture the dura mater, and behind the dura mater, the CSF of the patient would be present. You should also be aware of the fact that what is the most common complication of lumbar puncture? The most common complication of lumbar puncture is headache, because when you put the needle, it will tear the fibers of the dura mater, and when there's a tear of the fibers of dura mater, CSF will keep on leaking from that area. To make it sound sophisticated, in the MCQ, he will not write the word headache, he will write it as PDPH. PDPH stands for post dural puncture headache. So why are we using a thin needle? Why are we using a thin needle is to decrease the chances of post-dural puncture headache, because if I will use a thick needle, then the hole will be big and more CSF will leak. If I will use a thin needle, then less CSF will leak. So reason why I recommended 27G needle. The reason I recommended a 27G needle is because I want to decrease post-dural puncture headache. This is overall to be remembered as most common complication of lumbar puncture. Overall, the most common complication of lumbar puncture is dural puncture headache, PDPH. I want to minimize the chances of this happening, and that is why we should be using the thinnest possible needle in the patient. PDPH stands for post dural puncture headache. Then he can also ask you regarding the nursing responsibilities after lumbar puncture has been done. And the most important thing for you guys is that after the procedure has been done, the patient should be instructed strict bed rest. This strict bed rest would mean that the patient is supposed to lie in which position? Your answer will be supine position. Now, no head and elevation. Earlier, patient could be in a head and elevation, but after lumbar puncture, patient should be made to lie in supine position for minimum 8 hours, because when you will put pressure over that site of puncture, then there would be clot formation that will prevent leakage of CSF. Patient should be lying supine in that position, and that patient is saying, sir, I want to use the bathroom. I want to get up and go to the bathroom. We will say, no, we are not allowed to go to the bathroom. We will provide a bedpan to the patient, or like in a male patient, we can do a condom cath and like the person can urinate or defecate. So at this particular point of time, I want to ensure that meaning of the word bed rest is that no washroom access will be given to the patient. Like in a male patient, a condom cath can be used or a bedpan can be provided. Patient will insist, because see, for a normal person to urinate in the bedpan is difficult. It will cause soiling of the bed sheet, it will cause soiling of the clothes, it will be smelly, dirty. Patient will feel uncomfortable, but you will say, no, sir, you are not allowed. Patient will insist, no, no, sir, I can't. No, lying down in supine position, urinating is difficult now for anybody, male or female patient. So you have to be firm there. Now, no, sir, for 6 hours you have to lie supine. We want pressure over that area. We don't want to put some pressure bandage over there, but patient should be insisted to lie supine so that pressure will cause a clot formation at where the needle went inside. Because when a needle goes inside, the needle's blade, the lumbar puncture needle, right? The needle, lumbar puncture needle, if you have seen, it has a very sharp cutting edge blade. No? It has a double edge blade like this. The bevel of the needle has a sharp blade, like it's a double edged blade, as you can see. So it will cut, it will split the fibers of the dura. So pressure over that will cause a healing. What is the name of the lumbar puncture needle, by the way? Yes. The name of the lumbar puncture needle is Quincke's needle. The technical name of the lumbar puncture needle is called as Quincke's needle. This Quincke's needle will be having a double-edged blade, and this will be this will cause splitting of the fibers of the dura mater. The name of the lumbar puncture needle is Quincke's needle. It has a double-bladed needle, and that would result in like splitting of the fibers of the dura mater. That is why nowadays you will notice that in our hospitals, the needles that are coming are not having a sharp-edged blade, but are having a rounded tip. The advantage of the rounded tip will be that the trauma to the dura mater will be relatively lesser. So there is a second needle that I've currently made before you, which is called as Sprotte's needle. There are two needles which are available for doing lumbar puncture procedure. Quincke's needle and Sprotte's needle. Between the two, if they ask you to select one, which one will you select? Sprotte, because Sprotte will be causing less trauma. Sprotte's needle can be remembered as a traumatic needle. It will be causing less amount of trauma. As a result of this, like the chances of, you guys tell me, if you are using Sprotte's needle, then chances of post-dural puncture headache will be same, or will the chances be lesser? Lesser. So I hope I've been able to explain to you guys that two things are a must. One, use a thin needle. Use a Sprotte's needle, thin needle, Sprotte's needle, and ensure strict bed rest for 8 hours to minimize the chances of post-dural puncture headache in a patient. So condom cath or bedpans can be used. If in spite of this in the patient, there is a development of headache, then we will have to give a painkiller. I'm deliberately using a short form PTPH. PTPH means post-dural puncture headache. Post-dural puncture headache. Can you tell me the drug of choice of post-dural puncture headache? Caffeine. This explains why we can be giving to the patient hot tea and coffee. That is why you will notice that in Saunders it is written that hot tea or coffee, obviously it should not be so hot that it causes burning of the lips of the patient, because sometimes no accidentally you put a hot tea to your lips, the lips can burn or mucosa can burn. So do ensure it's not super hot, but then hot tea and hot coffee can be given because that will be having caffeine. And this moment I think all of you are aware of the fact that even in migraine caffeine will be working. Caffeine is a very good analgesic. Like I can mention a brand tablet, Crocin Pain Relief. Crocin Pain Relief is a 1 gram tablet of paracetamol that contains caffeine. So a lot of men and women who have migraine, they use Crocin Pain Relief tablet and they get instant relief because caffeine is a very good analgesic. In the MCQ, they might mention opioids also. They might mention opioids also, like codeine. Select opioids. Though I agree that opioids are more effective, but they have a side effect of constipation. One of the side effects of opioids is constipation. This itself is a question. Morphine, codeine, what do they cause? They always cause constipation. And because of the constipation, the patient will strain more, and straining will cause more leakage of CSF from the hole that was created. If you will give codeine to the patient, headache will go away. But because of constipation, the patient will strain, and the straining will cause gushing of CSF, and that will further worsen the headache of this patient subsequently. So we avoid giving opioids in a patient. We avoid giving opioids in a patient, and we recommend giving caffeine in a patient. Opioids are overall, I can say, not recommended. It is caffeine that is recommended. So hot tea and coffee can be given. So I mentioned steps for minimizing the post-oral puncture headache. I'll mention the points once again. Best way for minimizing this would be using a thin needle, 27G. Then would be to use a Sprotase needle. This is prevention. But the one that I've written at the bottom, this is not prevention, this is treatment. What is the treatment? Would be a strict bed rest, and is condom cath bedpan to be provided in a patient. Caffeine, hot tea and coffee can be provided so that we can take care of the post-oral puncture headache. And now we'll come to the main agenda, that what will be the findings in a case of meningitis. What will be the cerebrospinal fluid findings in a case of bacterial meningitis? The question will always mention the word turbid CSF because there is pus. The CSF findings in bacterial meningitis will be a turbid cerebrospinal fluid. The pathologist will see under a microscope and he will be able to see thousands and thousands of neutrophils. Whenever there is a bacterial infection, neutrophils will come in. To make it sound sophisticated in the MCQ, he may write the word polymorphonuclear cells. Polymorphonuclear cells or neutrophils basically means the same, that thousands of neutrophils are present. Security system is coming in. Security system is coming in. Then he will mention regarding CSF sugar. The bacteria will consume the sugar. Because the bacteria will consume the sugar, so the CSF sugar of this patient will be substantially reduced. The CSF sugar in this question will be deliberately given to be lesser. The reason why the CSF sugar is low is bacteria are consuming the sugar. He will also write about CSF protein. Protein will be elevated because antibodies are there, gamma globulin is there. So you will notice CSF protein will be elevated. We will also be sending the sample for CSF gram staining because we want to see whether gram positive or gram negative bacteria are present. And the microbiology department will also do a CSF culture because this culture report will take 48 hours to come, but it will tell us exactly which bacteria is responsible. From the laboratory perspective, what you are supposed to know is thousands and thousands of neutrophils with low sugar and elevated protein. Reason why sugar is low is bacteria will eat away the sugar because they need something for their energy, and proteins will be elevated because antibodies are there. Culture report will take how much time to appear? The culture report will take minimum 48 hours, but we will not wait. Listen to my words very carefully. We will not wait for 48 hours for the report to come and then start antibiotics. Antibiotics will be started in advance. That is what we call as empirical. It's okay. It's okay. Yeah, otherwise it will cause distortion in the mic. Empirical. What I mean by the word empirical is, what I mean by the word empirical is that we will not be waiting for the culture report to come, because culture report will come after 48 hours. So we will start the treatment in advance. One of the commonest antibiotics that you'll be using all your life, Monosef. Ceftriaxone 1 gram BD will be given to these patients along with second antibiotic. Can you help me with the second one, please? What is the antibiotic that is given second in all cases of bacterial meningitis? It is vancomycin. My question to you guys is, vancomycin is for staph aureus. Here there is no staph aureus, no? Then why are we giving vancomycin? Resistance. Streptococcus pneumoniae is turning resistant to ceftriaxone. That is why we are giving vancomycin. I would like to clarify that a lot of students are under the impression that vancomycin is for staph aureus. Agreed, it is for staph aureus, but it also works against streptococcus pneumoniae. So because of the problem of resistance nowadays, we are giving ceftriaxone with vancomycin empirically for management of this patient, and the total duration of treatment will be approximately 14 days. That they will not ask you, but I just wanted to explain to you that for 14 days, when you will give so many strong antibiotics, it will cause a lot of thrombophlebitis. No? You would have noticed, no, you put in a cannula, you have to change the cannula. So obviously substantial amount of thrombophlebitis would be developing. So suppose patient is not willing for IV injections, what will you do? IM तो दे सकते ना, we can give it in the buttocks of the patient. I mean, obviously IV is recommended because you get a higher bioavailability, but at least IM can be given to the patient. The message here is, because of extensive thrombophlebitis, you may not be able to get an access that you can put a PICC, peripherally inserted central catheter, and you can give antibiotic through that also, because these antibiotics cause a substantial amount of thrombophlebitis. So empirical ceftriaxone and vancomycin for at least 2 weeks are required for cases of acute bacterial meningitis, where the highlight was that the CSF report will be showing lots and lots of neutrophils with low sugar, elevated protein. Culture report will come after 48 hours, but antibiotics should not be waiting. Question for you guys, second one for today. Antibiotics should be started in suspected meningitis within how many minutes of admission? If you think meningitis is some small illness, no. Meningitis has 30% mortality rate. Meningitis can have 30% mortality rate. So the guidelines are that antibiotics should be started within 60 minutes of admission in any suspected meningitis. You know, lots of time in the emergency, limited doctors, limited nurses are there. So you will have to prioritize your work so that, you can't say that, okay, I will, first finish my work, then I will give antibiotics, because if I delay giving antibiotics to this patient, it can result in 30% chances of death of the patient. You see, on duty, let me say 2 doctors and 3 nurses or 4 nurses are on shift most of the time in government hospital. No, like limited number of doctors and nurses are on duty. Now, if you say, I will first take care of this male side, then female side, then I will go to this patient might lose his life. No, so lots of time we might have to prioritize giving antibiotic treatment. That is why they've created this guideline that within 60 minutes of admission in any suspected meningitis, bacterial antibiotics should be started. I'll repeat again, guys. If you think meningitis is some small time illness, no. Myocardial infarction has 1% mortality. Meningitis has 30. Heart attack has 1% mortality. Meningitis has 30% mortality, sir. Otherwise, these patients go into sepsis. These patients can die. They can go into septic shock. They can go into sepsis. They can go into SIRS. What is SIRS? Systemic inflammatory response syndrome. Systemic inflammatory response syndrome would be presence of fever in a patient. Along with fever, what will happen is tachycardia. Along with tachycardia, what will happen is increase in respiratory rate. Tell me the fourth parameter, though this is a old MCQ of your exam. What is the fourth parameter in systemic inflammatory response syndrome? There are 4 parameters in SIRS: fever, tachycardia, tachypnea. What is the fourth parameter? Total leukocyte count, guys. TLC can be more or it can be lesser. You're not supposed to forget that systemic inflammatory response syndrome is 4 parameters. Check out from the board. Fever, obviously, any infection will have fever. When you have fever, the heart rate will increase. When you have fever, the breathing rate will also increase. And when you have infection in the body, what happens to your total leukocyte count? increases. Normal total leukocyte count is 4,000 to 11,000 cells, so 4K to 11K. But if it is very severe infection, you may get a leukopenia. Like in COVID, you were seeing now people were having leukopenia. When your infection is very strong, then body is not able to cause a leukocytosis. You may get a leukopenia also. When do you say sepsis? Sir, out of these four, two should be present to say SIRS. If SIRS is present in any patient and there is a positive blood culture, then you say sepsis in a patient. Though this is old classification and is not used anymore because in previous NORCETs this has been asked, so I'm just covering that for you. What is definition of SIRS? Let me do the talking. Fever, tachycardia, tachypnea, and TLC. It can be leukocytosis or leukopenia. How many out of four should be present? Two out of four should be present. If somebody is having two out of four and blood culture is positive, then we will say sepsis in a patient. And then he is asked regarding the definition of septic shock. Because ultimately, if we delay antibiotic treatment, the person will go into septic shock. When will you say septic shock? You will say septic shock when somebody is having sepsis along with BP less than 90/60. If somebody is having sepsis and blood pressure of the patient is less than 90/60 for more than 1 hour, listen to my words very carefully. If the blood pressure of a patient is less than 90/60 in a sepsis patient for more than 1 hour in spite of vasopressors, I am giving vasopressors to the patient and still the BP is not picking up. That is when we say patient has gone into septic shock. And when you will not treat septic shock, the patient will go into multi-organ dysfunction, MODS. What is definition of multi-organ dysfunction? At least two or more than two organs will begin to fail, like the kidneys will fail, so there would be anuria. Urine output will drop in the patient, heart will begin to fail in a patient. When you have at least two or more than two organ malfunction, we call it multi-organ dysfunction in a patient. And this statement that I mentioned here before you is a generalized statement that you must know that what is sepsis, what is septic shock, what is multi-organ dysfunction, because this is how they will develop now. First person will develop SIRS. Then SIRS patient will go into sepsis. Then sepsis patient will go into septic shock. Then septic shock will cause multi-organ dysfunction and at least two or more organ malfunction will result in multi-organ dysfunction in a patient. Questions for you guys further? What is the vasopressor of choice in septic shock? Vasopressor, I hope pharma is done, right? Vasopressor of choice in septic shock. Options are dopamine, dobutamine, norepinephrine, epinephrine. Select one. Norepinephrine, NORAD. Vasopressor of choice in septic shock would be given as NORAD. Vasopressor of choice in septic shock would be NORAD. Meningitis is a dangerous illness in which antibiotic treatment should be started in 60 minutes, and failing which the person has the risk of developing all these complications. He will also ask you what is the target mean arterial pressure. Yes. I may not have discussed it here, maybe in the routine lectures, but I'm just trying to make it integrated today in front of you. That target mean arterial pressure should be more than 65 millimeter of mercury. Tell me the formula for mean arterial pressure. Very good. Very good. Systolic plus 2 times diastolic BP, whole thing divided by 3 is what is called as mean arterial pressure, which we should obtain as more than 65. What is the MAP for you and me while sitting in the classroom right now? 120 by 80, na? 120 by 80 systolic, diastolic. Put it mathematically. Mathematics for most nursing students is bad, but anyway. 95. Map of you and me. That is why you took biology. I took biology because my maths was bad. I was bad at mathematics. I took a biology, ratta lagana tha, and then I went into a college. So that's a separate story. But then the point is, like mathematics for most people is bad. That's why we take a biology. But at that point, you wouldn't never imagine one day you will have to sit in a goddamn class like this, listen to all these things. Okay, target map is 65 millimeter of mercury. Vasopressor choice in septic shock is NORAD in a patient. What is warm shock? What is warm shock? Normally in shock, are you supposed to have warm extremities or are you supposed to have cold clammy extremities? Cold clammy. But in septic shock, we have warm. How is it possible? You are a qualified nurse today. You are having a first year nursing student who's saying, sir, ma'am, shock means cold clammy extremities. You are telling me patient is having warm extremities. How is it possible? Is it possible? It is obviously possible. How? Yes, yes. In warm shock, you have bounding pulses. Look at the words I am writing before you. In shock, are you supposed to have bounding pulses or are you supposed to have thready pulse? In shock, normally just English. In shock, are you supposed to have a bounding pulse or are you supposed to have a thready pulse? Thready and a weak pulse. Na? Normally in shock, you should have a weak pulse. Look at the peculiar thing I'm writing. Bounding pulses, warm extremities. Your first year junior is saying, sir, all this is wrong. How is it possible, sir? Shock patient cannot have this. How possible, sir? How bounding pulse? Okay. How bounding pulse? Okay, look at the mathematics here. This mathematics is only to be listened here. It has no relation with the entrance exam. You are aware of a mathematical value called as pulse pressure. Pulse pressure is a difference of systolic plus diastolic. Like for example, the pulse pressure of you and me at the moment is 120 minus 80. So pulse pressure of you and me is the pressure that we feel over our radial artery, that is 40 millimeters of mercury. Now I want to tell you that what happens in septic shock is that initially in septic shock, it is the diastolic blood pressure that will fall. If diastolic blood pressure will fall, keep on looking at the board, look at the mathematics here. Just look at the mathematics here and tell me if diastolic blood pressure will fall. If diastolic blood pressure will fall from 80 to 60, what will happen to pulse pressure? Increases, and that is why the pulse will become more prominent. No? Pulse pressure is the difference of systolic and diastolic. In septic shock, which blood pressure falls initially? Is it the systolic blood pressure that falls or is it the diastolic? Diastolic BP. So the highlight of septic shock is why I'm teaching you this topic is this is only for like listening here. Otherwise, from MCQ perspective, just remember warm shock. But I wanted to give you the concept. Why do we call it warm? Is that if a pulse pressure will be more, so that means more blood supply. Now, more blood supply means extremities will also be warm here, and you will get a more powerful pulse. In septic shock, initially, everybody in septic shock initially, which blood pressure will fall? Diastolic. When diastolic will decrease, what will happen to pulse pressure mathematically? Increases. That explains the bounding pulses in a patient. But in the same patient, in the later part, we have development of cold shock. Cold shock means that now systolic will also fall and diastolic will also fall. So I'm making the systolic also fall now. Let me say systolic is falling to 90. And diastolic is falling, let me say 60, let me keep it 60 only. Now look at the data and tell me what will happen to the pulse. Will it become more powerful or will it become less powerful? Mathematically, less powerful. No? So that's why I was saying cold shock manifestations. This is mathematics. You don't need to get into it. I just want to tell you that in septic shock, initially, which blood pressure will fall, guys? Diastolic. And later, diastolic and systolic both will begin to fall. In septic shock, what happens is first diastolic BP will fall, then systolic plus diastolic BP will fall. All this mathematics you are not expected to like remember or note down. But what you have to remember is that warm shock is the initial presentation. Warm shock is the initial presentation. I'm writing the word cold shock again from the perspective that ultimately, even in septic shock, you will be getting a weak pulse that is called as a thready pulse. And you would be getting is cold extremities. Guys, meningitis is not a small illness. It can result in sepsis. Sepsis is a topic that they love to ask in your exam. So they can ask you about warm shock. They can ask you about cold shock. And now is those MCQs pharmacology. What is the main vasopressor in warm shock? You have answered very rightly. It is NORAD. But if I change it to what is the vasopressor in cold shock, then guys, I need to increase systolic BP also. Norepinephrine increases only diastolic blood pressure. Norepinephrine increases only diastolic blood pressure. In cold shock, systolic was also falling, diastolic was also falling. I need to increase both of them. If you remember your pharmacology, the drug that increases both systolic as well as diastolic is epinephrine. So do remember that statement. Ultimately in your exam, no, it is not the whole logic. It is the facts to be remembered. Look from the board and tell me what is the vasopressor of choice in warm shock? Norepinephrine. What is the vasopressor of choice in cold shock? That's the point to be remembered. Everything else was explanation, but I just wanted you to be yielded to this information. Vasopressor of choice in warm shock is NORAD, norepinephrine. Vasopressor of cold shock is epinephrine. Epinephrine will increase systolic also and will increase diastolic BP also. Epinephrine is obviously used in cardiac arrest. But today I'm not talking about cardiac arrest. I'm not talking about pulseless electrical activity. I'm talking about shock where epinephrine will be used and it will increase the systolic as well as the diastolic blood pressure of the patient. The objective was to sensitize you to the possibility of why patients can die if the interventions are not done. And now I will shift gears and mention regarding viral encephalitis because meningitis is usually bacterial. But sometimes in MCQs they can give you regarding viral encephalitis, which will cause us brain fever. What are the buzzwords in the question? The buzzwords would be there would be fever. This fever might be only for 1 or 2 days. The patient might be having presence of fever for only 1 and 2 days. And what will be present along with this? There will be no nuchal rigidity in this particular question. Headache may or may not be given, but what will be given is that this person is not recognizing his family members. He is not recognizing his son and daughter, altered sensorium or altered mentation. If you ever read that within fever of 1 or 2 days, person is not in a position to recognize family members, we will think in terms of inflammation of the brain parenchyma, that is encephalitis. Difference between meningitis and encephalitis is in meningitis, the infection is in the coverings of the brain. And in encephalitis, the infection is occurring in the brain parenchyma. If I draw a diagram like this, suppose this is coverings of the brain. This is brain parenchyma, coverings of the brain. In first, I was saying that the infection is present here in the covering. Meningitis. In encephalitis, the infection is in the brain parenchyma. I've just drawn a crude diagram to represent. In meningitis, in a case of meningitis, the infection is in the coverings of the brain. The dura mater, the pia mater, and the arachnoid mater, that is where the pus is present. But in encephalitis, where is the infection present? It is in the gray matter and white matter of the brain. Meningitis would be infection that is present in the coverings of the brain. Encephalitis is an infection of the gray matter and white matter of the brain where the person will not be in a position to remember his family members. What is the reason for development of this particular scenario where a person can be not in a position to remember his family members within fever of 1 to 2 days? You can see that every year in India, especially after the rains in the month of September or October, especially in the state of Kerala, we have outbreak of Nipah. The Nipah virus infection causes development of encephalitis. So especially if they mention Kerala, then one of the virus that is to be remembered is Nipah virus. And how is Nipah virus transmitted? It is due to bats. The reason for the transmission of Nipah virus will be answered by you as consumption. The reason for spread of Nipah virus is consumption of fruits which are contaminated with the saliva. It is consumption of fruits which are contaminated with either the saliva or the fecal droppings. It is consumption of fruits contaminated with saliva or fecal droppings of the bats. And what is the technical name of the fruit bat? The technical name of the fruit bat is Pteropus. Pteropus is the scientific name of the fruit bat, which the media tends to call as flying fox. Obviously, it is not a fox, it is a bat. Media people, they don't have too much of knowledge, so they call it a flying fox and all those things. But it is Pteropus, consumption of fruits contaminated with saliva or fecal droppings of Pteropus. Another reason for transmission of Nipah virus would be consumption of date palm sap. You know, date palm sap, that tree, no, from there the date palm sap is collected to make alcohol. So bat is saying, I also want to drink alcohol. So bat also went to have some consumption of alcohol, and then people who consumed that alcohol ultimately also fell sick. You would also be aware of the fact that this is present in body secretions. Human to human transmission is there. Way back in 21 or 22, I remember there was one case where the patient had a seizure. When the patient had a seizure, there was a lot of frothing at the corners of the mouth of the patient. So the nurse who was on duty, she was not aware that this is a case of Nipah virus. So she just took a gauze piece and she cleaned the saliva. Like, when patient will have seizure, they will be frothing at the corner of the mouth. The nurse was not aware of the fact that this is Nipah virus infection. So she took a gauze piece and she just cleaned the secretions on the side of the face of the patient and threw it in the dustbin. But the virus came on her hands. Now, multiple times in a day, we tend to touch our eyes or our nose, and that means she got infected and she died because of it. It is later when we investigated, we found that this nurse had died because of Nipah virus infection, and that is when they put in the quarantine, and then after that, strict protocols were ensured. So now, obviously, we are more aware, so they will provide PPE, and everybody will be using gloves and masks, etc. But then, human to human transmission of Nipah virus has also been documented, and human to human transmission means that it is present in body fluids, that is in the saliva. Can you tell me the cause of death in Nipah virus? Can you tell me the cause of death in Nipah virus? Yes. Good morning. We're discussing encephalitis today. The topic of interest. What is the topic of interest? Brain fever. Non-medical people call it brain fever. That brain fever is encephalitis is the cause of death. Guys, the mortality rate with Nipah virus is almost in the range of about 40 to 75%. You would remember COVID days. I think you were the COVID batch, right? You would have started your nursing in COVID time only. Approximately 21, 22, like that. So my point is that that Delta strain was having mortality of 20%. Delta strain was having a mortality of 20%. Nipah has a mortality rate of 40 to 75%. So thankfully, like every time there's a lot of quarantine in Kerala, and that is why we are able to control it. And this year, even in the month of February, this was reported in near Kolkata, Darjeeling. So Nipah is the infection. Now it causes turbulence in the mic otherwise. Yeah, you can turn towards them, not towards me. The mortality rate is 40 to 75%. So this is a dangerous infection that you need to be aware of in Kerala. Now we move to North India and we go to the state of Uttar Pradesh, Gorakhpur. Gorakhpur this year and maybe last year, they've not had cases because of extensive vaccination. But even in your PSM classes, sir would have taught you that now Japanese bee encephalitis vaccination is a part of the national immunization schedule. So my request to you guys is to read about the vaccines for Japanese bee encephalitis yourself from PSM. Both the live vaccines and the killed vaccines can be asked to you. Please read about the live encephalitis. Most of the time in India, either of the two possibilities will be there. Either it will be Nipah virus in South India, or it will be South India and East India will be Nipah virus. East would mean Darjeeling and all those places. If we go up north, then it will be Japanese bee encephalitis. Japanese bee encephalitis is because of the nuisance mosquito. What is that mosquito that grows in dirty water? Like after the rain, stagnant, dirty black water is there. Culex. Culex is called as nuisance mosquito. Culex is called as nuisance mosquito. It can grow in dirty water, like Aedes will grow in clean water. But this will grow in dirty water. So in that drains also this mosquito will grow. So luckily they've done interventions to prevent the breeding of the mosquito and vaccination. So because of that, Japanese bee encephalitis has shown a downward trend in India. On a global basis, the number one cause, however, will be answered as herpes. Now the trick in the MCQ will be herpes simplex 1 or 2. So remember, 1 is upper part of the body, 2 is the lower part of the body, because herpes simplex 2 causes STD, sexually transmitted disorder, genital herpes, but this is herpes simplex 1 encephalitis. This herpes simplex 1 encephalitis is so dangerous that if treatment is not done, the patient will lose his complete memory. Our memory is stored in our temporal lobe. And herpes simplex 1 virus has a tendency to damage the temporal lobe of the brain. If this virus is not treated, the person will be becoming like Alzheimer disease patient. Like patient will not even remember the personal details like phone number, mobile phone number, personal detail, name, etc. Like person will develop amnesia because you know that this infection is so dangerous that a person might lose completely his memory. So we will be starting empirical acyclovir, obviously because it is a viral infection. So empirical acyclovir will be started. Guys, there is no treatment available for Japanese bee encephalitis. There is no treatment available for Nipah virus at the moment. We have treatment for only one, herpes simplex 1, that is empirical acyclovir is started. The investigational choice for diagnosis of this condition will be cerebrospinal fluid. We will take the CSF of the patient. On the CSF, we will be doing a PCR. Polymerase chain reaction, we will be doing a PCR CSF for herpes simplex 1. This report facility may not be available in Bengaluru, so I might have to send the sample to Mumbai, maybe to Delhi. That report may take 2 days, 3 days, maybe 2 weeks, 3 weeks to come. I will not wait for the report to come. I will start the antiviral treatment even pending the report. The best test for diagnosis of this condition is CSF study for herpes simplex. But even pending that, we will be starting acyclovir for management of this brain fever, as I've explained to you at the moment. So there are 3 reasons for brain fever in India where infection of the brain parenchyma will occur. Nipah virus down south, Gorakhpur up in the north, and global basis, it is herpes simplex 1 encephalitis, which causes infection of the gray matter and white matter of the brain. So I've talked about meningitis and encephalitis. To finish this topic and move on to the next one, I will lastly mention regarding a fungal meningitis. I have a HIV positive patient. He is having AIDS. In patients of AIDS, there can be a development of fungal meningitis. Prior to this, I talked about bacterial meningitis, I talked about viral encephalitis, but now talking about fungal meningitis. The name to be remembered is very peculiar. When I will write the name, I'm very sure you would have read it at least once in your life. That is Cryptococcus neoformans. Cryptococcus neoformans is one of the important causes of fungal meningitis in AIDS positive patients because immunity of these patients is low. Because the immunity of these patients is low, that is why this Cryptococcus neoformans is asked to you. Cryptococcus neoformans comes from pigeon droppings. How does this infection spread? This infection will spread through inhalation of dust that is containing pigeon droppings. Pigeon is a pest. In the feces of the pigeon, lots of dangerous fungi are present. This is the reason why nowadays some cities in India, like Indore, has banned the feeding of pigeons. Even Mumbai has banned the feeding of pigeons because pigeon is a pest. You see, you would have seen in cities that hardly any sparrows are present. It's all pigeons everywhere, and people feed the pigeons. They think that it is a good thing that they're doing. They're not doing a good thing because when pigeons populate an area, no other birds are visible, not even crows. Crows are supposed to be sturdy animals, no? Sturdy birds, black crows. Even the crows will die because all the nutrition and food will be foraged by all the pigeons, and present in the fecal droppings of the pigeon are multiple fungi. Lots of time in our houses on the air conditioner on the top of our AC, the pigeon will make a nest and we will say, okay, don't disturb the pigeon, it is laying eggs. The filter of the AC will not be able to prevent the fungi entering into our lungs. These fungi, that is the reason a lot of us might be having fever, cough, upper respiratory tract infection. Your and my immunity is good. So Cryptococcus infection of the lungs will be killed because our immunity is normal. But if somebody's immunity is low, then the same infection will go from the lungs by the blood to the brain. The infection will cross the blood-brain barrier and will go in the brain. Because this problem had become so severe that in Maharashtra, in Mumbai, they banned the feeding of pigeons. In Indore, they banned the feeding of pigeons. If somebody is caught feeding pigeons, they will put a fine of 500 rupees on that person. People still do that. But why, like the health authorities have to do this is because non-medical people don't think. They think, oh, we are feeding the pigeon. No, we're doing some noble work. We are trying to allow some population of some birds to increase. But pigeon is a pest. The blue rock pigeon is a pest. Present in the fecal matter of the pigeon is histoplasma that goes in the lungs that causes lung infection. You and me have good immunity, so we don't realize it. Within 1 to 2 days, the fever will go away, cough will go away, so it's okay. But AIDS positive patients, immunity is lesser. That is why the problem will occur. The investigational choice for diagnosis of this particular infection is lateral flow assay on the CSF sample. Lateral flow assay is a ELISA based test. We can do a lateral flow ELISA, lateral flow assay on the CSF sample of the patient. To confuse you in the MCQ, he may deliberately write the word urine because the fungus is being shed in the urine of the patient also. So we can check it in the CSF, but we can check it in the urine, we can check it in the blood also. So don't be surprised that in MCQ, he may deliberately not write the word CSF, he might write the word urine. He wants you as a nursing officer to understand that because the virus is present in the body, it will be shed in the urine also. It would be shed in the urine also. Now for the treatment of this condition, they will ask you the drug of choice. This is the same drug that was used in treatment of even mucormycosis. You are the COVID batch, you would have seen after COVID there was infection of mucor infection. People were having that black discharge from the nose, and people were having then proptosis developing rhinocerebral mucormycosis. So we use the same drug that we use in mucormycosis for treatment of this infection, that is liposomal amphotericin B. The complete treatment of fungal meningitis Streptococcus neoformans is liposomal amphotericin B with 5-flucytosine. Not 5-fluorouracil. That 5-fluorouracil is going to be anti-cancer drug. I'm not talking about anti-cancer drug. I'm talking about antiviral drug. 5-flucytosine will be used. This treatment will be given intravenously for 2 weeks. After 2 weeks, we will discharge the patient or oral fluconazole. This oral fluconazole will be given to this patient for 1 year. Guys, I hope you appreciate we treating the patient for 1 year. You can understand how dangerous this infection is, that we are giving oral fluconazole for how long? For 1 year. Because CD4 count in the AIDS patients is substantially low, so there is the risk of reinfection. So you can see the treatment of this condition is almost 1 year and 14 days. That is why this is asked in the exam, because this is going to be a long-standing treatment that we give to our patients. Cryptococcus is a fungal meningitis that is seen in AIDS patients, because in AIDS patients, CD4 count will become lesser. How much is the normal CD4 count? How much is the normal CD4 count, guys? You can take an average of 1000. The range is 800 to 1200 cells per cubic millimeter. Remember, average value 1000. When CD4 count will become less than 500, the commonest opportunistic infection to occur in AIDS patient will be tuberculosis. When the CD4 count will go down to 200, there will be a development of pneumonia. This pneumonia is what is called as pneumocystis jirovecii infection. When the count will go down to 100, that is when this meningitis will occur that we were talking about, that is Cryptococcus neoformans meningitis. When the count will go down to 50, this AIDS patient will become blind. Blind, blind. He will become blind. That is cytomegalovirus retinitis. Must know information for today. You just can't afford to miss any one of these questions. They're super scoring and easy questions. Normal CD4 count 1000. If the cells count decreases, we get opportunistic infections. They love to ask about opportunistic infections in AIDS patients. They love to ask about opportunistic infections in acquired immunodeficiency syndrome patients. So this is something that I'm discussing in an integrated fashion. Like I'm not discussing AIDS separately, but I'm just discussing that your opportunistic infections will occur in a patient, and one will be a brain infection, Streptococcus neoformans. Okay, a few words about AIDS before we go forward. What is the most common route of transmission of HIV infection? Sexual, vertical, needle stick injury, blood transfusion. 1, 2, 3, 4 is answers, please. Voting. I can hear a blood transfusion. That's a good answer. More people, please. One is sexual. Fourth is blood transfusion. What is the most common route of spread of HIV, guys? Sexual route. The most common transmission route is sexual route. The blood transfusion is separate MCQ. Most efficient transmission. There are two separate MCQs of a paper. Please read the wordings carefully. NORCET exam is all about English. No great concepts. They just play with English and your career. You miss one word, you're gone out of competition. As simple as that. Right? You miss one word, I'm saying, sir, it takes a lot of effort, right? To sit in front of computer for 2 hours. Right? You have to go for the paper in the morning. Travel again something. Travel is something again. Uber might cancel something. When you least expected, something will go wrong, right? So you will reach the center at the last moment. And when you reach the center at the last moment, when you sit in front of computer, sometimes computer may switch off. And they will not give you extra time for that. I was taking Delhi, I was talking to a guy who's a tall guy, right? He's second or third attempt this time. So he's a tall guy, right? They gave him a small chair to sit. So he sat on the chair and then he said, I was feeling like cramped, because space is very less, near candidates, no? So he stretched his leg and his foot hit the electrical cable, computer went dead. He said, I started sweating from every pore in my body. He says, like, I had prepared for 1 year and like I could feel the sweat dripping from every hole in my body, in fact. And he says, like, the computer administrator who came, no, he could not fix it. So he called the center coordinator. So it took almost 15 minutes for the computer to be started. And by that time, like when he says when the computer started, then the timer was still on. So they don't give you extra time for that, no? If the timer is on, that means the paper is on, no? So lots of time, I mean, Murphy's law, no? We call it Murphy's law. The worst things will happen at the time when you expect them the least. Your capacity should be such that you should not hyperventilate and you should not lose your calm. See, all of you are intelligent people, right? Hardworking and intelligence is a separate issue. Keeping calm is a totally separate game. I have seen a lot of hardworking, super intelligent students who get top ranks in colleges and everywhere else. Here in these tests in the academy, they'll score very well, but in the paper, something happens to them and they just lose it in the paper. If you're sitting, especially if you're a second attempter or third attempter, you will be feeling that pain more when I'm speaking in front of you. If you're a first attempt, you'll say, what the hell, I'll do it, right? At first attempt, you are like, ignorance is a bliss now. When you go through that fire, that is when you realize the pain that comes. Because when parents will ask, na, kya hua? You don't have an answer, no. We paid for your coaching. We paid for everything you said. Look at your Swiggy bill. Look at your so much of money you have wasted. Right? Parents will obviously scold. Parents are not scolding you in the bad way, but they'll always scold you. They'll ask you what did you do? So you say I missed it by 1 mark. It's not an excuse. No, India is such a nasty country, man. Indian system. One MCQ to two MCQs max. You see, one they say fail. Second, or both are four-letter words, not the four-letter word we're thinking. Right? Fail and pass, both are four-letter words, but they're dramatically different. No? I mean, the body language of a person will change. I've seen people, brilliant guys, the shoulders start drooping, man. When 2 attempts, they're not able to make it. A third attempt, they might be brilliant boy or a girl. When they went to the third attempt, the shoulders start drooping. They don't feel like studying. That is why I said right today here that make this your first attempt and the best attempt, because first is always the best attempt, right? Irrespective, and if suppose it's your second or third, then you don't need to feel bad about it, but then you don't need to ruminate about what happened earlier. You have to put in and everybody studies in the end only, right? If exam is postponed, luckily, suddenly this exam is postponed, you will stop studying. Then moment the date will come closer, again the pressure will come. It's not about studies, it's not about IQ. Let me be very frank. No exam in India is about IQ. Right? IQ is American exams. There they test your real IQ, NFLEX or like USMLE. That's where they test your real clinical forte. India is all about like keeping calm and being able to perform under pressure. Like there's no electricity, it's hot. Lots of time in centers, no, there's no electricity. It's hot, and people are sweating. One guy said there's so much of sweating on my forehead. I was literally licking my sweat, tasting my sweat. It's gonna be so hot, right? So he said I felt like a commando training more than the academic part, the commando training. But anyway, coming back to the agenda, most efficient route of transmission is gonna be blood transfusion. The most common route of transmission is sexual contact. HIV viruses are two varieties, one and two. One, yeah. Break. Somebody said break. Uh, okay, give me like 5 minutes. 5 minutes. Right. Okay. Then I'll give you a break. Right. I know you're tired. It's okay. HIV-2 is more common in Africa, and one is common in India. Just general data, then I'll give you a break. Okay, which is more dangerous, Indian virus or the African virus? Indian or African? People saying Africa. Why are you being so racist? Right. We are also dark people, no? Sir, Indian virus is more dangerous. Obviously, they did not ask like this. They asked like this, that how many years will it take for conversion of HIV-1 into AIDS? And how many years will it take for conversion of HIV-2 into AIDS? So the African virus will take 15 to 20 years, and the Indian virus will take 10 to 12 years. So all those racist people sitting here, now tell me which is the more dangerous one. Indian virus. Indian virus will take how many years to convert into AIDS? 10 years. So HIV-1 converts into acquired immunodeficiency syndrome. Question for everybody. Acquired immunodeficiency syndrome is said to be present when patient's serum ELISA for HIV is present, positive. HIV-1 and HIV-2, we test both of them along with CD4 count. Yes, guys. When do you say AIDS? Serum ELISA HIV positivity with CD4 count less than how much? 200. Which can also be asked in percentage, then your value will be less than 14%. AIDS is acquired immunodeficiency syndrome, that is serum ELISA for HIV positivity plus CD4 count less than 200 or less than 14% is the definition of acquired immunodeficiency syndrome, and we get opportunistic infections developing in these patients. The most efficient route of transmission is blood because it will be having higher load. But if he says not efficient, he says overall most common, then it is obviously the sexual route of transmission, which is overall the most common one. And you and me as doctors are exposed to another risk, that is needle stick injury. You are the nursing officer on job today. You are supposed to put cannula in a HIV positive sex worker. You know patient is HIV positive. The young nursing officer had taken a sample from the patient or had put a cannula. Whenever you take a sample from the patient, if you do bedside sampling, you are supposed to never put the cap back on the needle. Recapping of the needle is never to be done. Right on the first day of your joining, you are given an orientation in which you are taught that never after a sample put a cap back on the needle. If you put a cap back on the needle, there's a possibility that if your concentration will waver, you could end up putting the cap back on the needle, but the needle might accidentally prick you on the non-dominant hand index finger. That's again a question of your exam. The PSM teacher would have also studied that the most common site of needle stick injury is non-dominant hand index finger. This young nursing officer did not pay attention, and he or she was trying to put the cap back on the needle and got a prick. The moment he got a prick, obviously the young nursing officer had put double gloves. He knew patient was HIV positive, so he was using double gloves, but the cutting edge of the needle is so sharp that it can go through the double gloves, so it was obviously pain. So he removed the gloves, there was visible blood, and he's freaking out. And he's your junior, so he's asking you, sir or ma'am, what are the chances that I will get infection? He's calling you on the phone, he's saying patient is smiling. Heartless patients of India, no? Patient is saying, welcome to the club. You would have seen recently a video viral where a doctor was beating up a patient and the doctor was arrested subsequently. That patient had not disclosed that the patient was HIV positive. Patient was admitted for a couple of days. And like later, multiple people were coming in contact with that person. Obviously, it's wrong to beat a patient. But strange things happen, no? Patient hid the information that person is HIV status. Now, if you're not aware somebody is HIV positive status, you will not use normal precautions and you'll be coming in contact with body fluids of the patient. No, you have to put Foley's catheter, you have to put a NG tube, you have to put a cannula in a patient. So when you're coming in contact with body fluids of a person who's HIV positive, I mean, nobody would like to, come in contact. So obviously, like in India, wrong things happen. Obviously, the violence does not justify it. It's obviously wrong that things like these should not happen. But then we as healthcare workers are super exposed to this. And nowadays you will notice that after truck drivers, truck drivers in India, because truck driving wherever those are brothels, etc. are there, no? The brothels where underage girls are there, brought in from, different countries, and they do all these illegal things. They pay extra to have unprotected sex. If in PSM posting, we are posted to do counseling of these truck drivers, etc. And you will notice that when you talk to these people, now the kind of language they use, filthy language they use, you will not even feel like eating for one day. Like that, no, scum of the earth, no. Sir, in PSM, you have to counsel a sex worker. You posted in STD clinic, you counsel a sex worker, you counsel these truck drivers and all these people. So, I mean, when you will talk to these people now, you will realize really that filthy kind of things and the filthy feel that you will get, that you will feel like, oh man, like this is just too much. That's the reason why the disease spread. And now what happened? What happened was that these people, these truck drivers will now go and will transmit it to their wife. Now, when wife will come to government hospital, there you and me will be working. When we will do sampling, we will also get the infection. So from truck driver, the disease is coming in the community, and from community is going where? Healthcare workers. That is why you will notice nobody in Bengaluru in private sector, no doctor, no nurse will take delivery. They'll refuse to take delivery, sir. Even Asha worker nowadays know this. Even Asha worker, PSM, she can take delivery at home. Even Asha worker is aware of the fact that HIV transmission can happen. So she will refuse to take delivery of a HIV positive patient. She'll say, go to government hospital, go to Bengaluru Medical College. Right? If Asha worker can be, Asha worker, whatever is 8th pass, 10th pass, something like that, no? Whatever. The point is that this is the amount of disease spread that has occurred in the country. And obviously, like we have tried to control the spread. But anyway, the point is, what are the percentage of chances of transmission? Chances are 0.3%. But can you decrease the volume of this? My voice is coming back to me. Volume of this, if you can just decrease. Okay. Yep. Chances are 0.3%. So this doctor or nurse, he got a prick. And now when you told him 0.3%, obviously the guy got scared. Like this guy literally dropped his mobile phone. Like he's talking to you, you are the senior, you said 0.3%. So he said 0.3%. Oh my God, I could be that person. So he dropped his phone. Then he got back on the call. Okay, okay, boss, what should I do? So what is the advice? Yeah, post-exposure prophylaxis. Yeah, that's the point. Tell me the drugs quickly. TLD, tenofovir. Continue talking, guys. Yeah, it is for this that I made you sit here. Tenofovir, lamivudine, and dolutegravir. Though this discussion is slightly different from the CNS infection component, but because these aspects are asked in the paper, that is why I wanted you to be aware of the post-exposure prophylaxis TLD. This should be started within how many hours of exposure? Guys, that's a separate MCQ. Answer is as soon as possible, preferably within 4 hours of exposure. That is a separate MCQ. It is not effective after 72 hours. There are two different MCQs. Be careful while attempting them. Obviously, your answer is partially right because we have to give it within 72 hours because it is not effective after. That's the language of the question. Not effective after 72 hours and should be started within preferably 4 hours of exposure or as early as possible. The next aspect is what is the duration? That would be 28 days. Must know fact, guys, this is something that you can never be expected to go wrong. Even in the middle of your sleep, somebody wakes you up and says, okay, tell me what is post-exposure prophylaxis. You should be spot on for these kind of questions. Needle stick injury is very rampant nowadays, guys. Another infection that I would just like to introduce before I say the word break is hepatitis B. With hepatitis B, the chances of transmission are huge, 30%. So today, a young nursing officer has done sampling of a hepatitis B positive patient. He's surface antigen positive. His patient is surface antigen positive. While putting the needle back, while recapping the needle, which should not have been done, the young nursing officer has got an accidental needle stick injury on the non-dominant hand index finger. 30% chances of transmission are there. Because 30% chances of transmission are there, you are his senior, so he's asking you, boss, like don't tell me, don't tell my girlfriend. She says, I got a prick from a hepatitis B positive. No, at least please don't tell my girlfriend. Will you tell the girlfriend of this guy? Suppose she comes and wants to know. Will you tell? Yes or no? Yes or no? Just a quick answer. Yes or no? There's something called as patient confidentiality. You need to respect that, right? Just somebody comes and says, I'm this boyfriend, girlfriend. Like, will you say, like, I will tell the report? No, no, will not tell the report. Okay, coming back to the agenda. What will you do? Send him to the hospital casualty where they will be giving hepatitis B immunoglobulin. You as nursing officers are supposed to be aware of these algorithms which are designed to prevent healthcare workers. That is, the healthcare worker should be given passive immunity. Hepatitis B immunoglobulin intramuscularly, preferably should be given within 24 hours of the exposure. All of this is available free of cost to all healthcare workers. It can be, he can mention the word laboratory technician, he can say doctor, he can say healthcare worker, he can say nurse, but hepatitis B immunoglobulin means ready-made immunity. So passive immunity should be given in this particular case and should be given within 24 hours of exposure. The risk of transmission is approximately 30% for hepatitis B and for HIV is 0.3%. So it was slightly off the track, but I still wanted to introduce this concept regarding protection for healthcare workers. Suppose somebody gets HIV infection today. Suppose somebody gets HIV infection on day 0, then ELISA test will turn positive on which day? If somebody gets HIV infection today due to any reason, it could be sexual contact. A young guy, college student, went to red light area, unprotected sexual exposure. It could be needle stick injury in a healthcare worker. It could be blood transfusion. ELISA test will turn positive on which day? Day 23. ELISA test will turn positive on day 23. This means that if the person will donate blood in this 23-day period, this means that if this person will donate blood in this 23-day period, then the report will be negative and we will take the blood of this particular person and give it to somebody, the person will turn HIV positive. This happened in Stanley, this happened in Chennai, Stanley Medical College, that a person had actually had an unprotected sexual exposure and he had given blood. He went for a blood donation camp, like in college blood donation camp happened. So he went for a blood donation on 7th day and his ELISA test was negative. So the blood bank received the blood and when they gave this blood to a pregnant lady, she became HIV positive later. This is what is called as window period. So can you tell me what test can be done in the window period for early detection? We can do a P24 antigen. All of you would have done this MCQ. P24 antigen turns positive on day 15. I put up a question to you guys. A guy had an unprotected sexual exposure today. You told him P24 antigen will turn positive on 15th day. He says, sir, can't you tell me a test that will turn positive earlier? Can you tell me a test that turns positive between 7th to 10th day? PCR, HIV RNA. Remember my words, for any infection in the paper, they ask you, what is the test to be done? Just answer PCR. Your answer will always be right. For everything we do a PCR only. Na PCR, HIV, RNA will be helpful in early detection. Let me do it again. A laboratory technician got prick from a patient on day 0. What test should be done in this healthcare worker for early detection of HIV? PCR. If PCR is not in options, what will you answer? P24 antigen. If this is not positive, what will you answer? serum ELISA for HIV. The objective was to sensitize you to the fact that if they specifically say needle stick injury in a healthcare worker for HIV, which is the best test to be done? Then answer is PCR. Then is P24 antigen, and then is serum ELISA for HIV. And anyway, CNS, I mean the HIV part, as I've explained to you, is that when the patient will go into AIDS, which is couple of years later, then the patient will go into AIDS. A couple of years later, the CD4 count of the patient will begin to fall. This you can just listen. When the count will decrease to 500, the opportunistic infection will be TB, which is the most common opportunistic infection. When it will be less than 200, there will be girovasi. When it will be 100, there will be cryptococcal meningitis. That is where the discussion started from. And when it is less than 50, the person can turn blind. That blindness would be cytomegalovirus retinitis occurring in a patient. So my objective was to talk about infections from the brain perspective, including the HIV aspect, which I wanted to introduce before you, especially from the perspective of CD4 count and a couple of these tests that I've highlighted. Some of this might be having overlap with PSM also. No, maybe the PSM teacher would have said a couple of these facts as well, but I've tried to talk about it in an integrated fashion so that you can remember this information. Minimum that I expect you to know right now, right here, is these values: 500, 200, 150, because they usually like to ask about these aspects. So I'll describe a case before you. This case, I'll not straight away start with like, is it extradural, subdural hemorrhage? I'll give a case with scenario, explain to you the head injury, and then I'll expect the answer from your side. Like, let me say this is a 60-year-old lady. She's a known case of type 2 diabetes. Now, this lady has a good habit that she wakes up in the morning and she takes a bath, and then after the bath, she goes to the temple for praying every single day. Today morning, she woke up at 5:30 a.m. She went to the washroom, and maybe the floor of the washroom was wet. So she slipped in the bathroom and her head slammed against the wall or slapped against the tap or any other object per se. 60-year-old lady, type 2 diabetes, has slipped in the washroom. Her head slammed against a wall, and obviously when somebody will fall in the washroom, then there would be loud noise. Also her son or daughter-in-law, whosoever was at home, came running that, okay mama, what happened? The bathroom was locked. So his son or daughter is knocking from outside, mama, are you okay? And she did not give an answer because she might have become unconscious for a short duration, because somebody will fall on the head and there's a bump on the head, then patient can become unconscious for a duration. So initially son or daughter is saying that my mom did not give an answer. Finally, she opened the door. She would have regained consciousness and she told her son that, no, I am fine. But her son had noticed that she was having a bump on the forehead, because when somebody will fall on the floor, then obviously if the head will slam against the floor, there can be a subperiosteal bleed. So her son has noted a bump on the forehead also, that is a subperiosteal bleed is present. And therefore, in this particular case, his son said that, mom, let's go and show a doctor. But this lady refused, because most elderly people will like not want to go to a hospital. So this lady, like, she, after the fall, she took a bath. She then went to the temple also. She cooked food for the family also. Everything was fine. But from the next day onwards, like, she has fallen one day before, but next day onwards, like, she's becoming very sleepy. There is increased sleepiness or drowsiness being noticed by son. The son of this lady is saying that my mom always wakes up at 6 o'clock in the morning. She takes a bath. She goes to the temple every single day. Then she's busy in the kitchen like all mothers are. But I don't know what has happened. After the fall, I'm noticing that my mom has become very drowsy. She has also become very forgetful, and she's also become very irritable as well. Normally says that my mom is like always working, but I've never seen my mom sleeping so long. But for the past 2 or 3 days, she had fallen 2 3 days ago in the bathroom, and now she's sleeping very long, and she's not waking up, or she's becoming forgetful. So they decided to come to the hospital. And when I listened to the history that the lady had fallen in the bathroom a couple of days back, I advised a CT scan. When we did the CT scan of this lady who had become forgetful, she was drowsy, she was irritable. I'm going to hand draw the CT scan before you, just to explain the findings that can be given before I give the final answer for the raise ICP in this case. On a CT scan, you can see the bone. You can see the ventricles of the brain, like in the brain, we have lateral ventricle, we have the third ventricle. So this that I've shown is the third ventricle, and where I put alphabet L is the lateral ventricle. And now I'm gonna show the bleeding in this particular patient. The bleeding will always appear white on a CT scan. The bleeding will always appear white on a CT scan. Now, obviously, I can't draw white because that will not be visible, so I'm drawing it relatively gray. But what I've shown is that this lady had fallen in the bathroom couple of days back, and what you can see in the CT scan of this patient is this white lesion. The shape of this white lesion that I've currently shown before you is concavo-convex. The shape of this lesion that I've currently shown is concavo-convex hyperdensity. Whenever in the CT scan we are able to see anything white, we call it hyperdensity. If we see anything black, we call it hypodensity. So on the MCQ, he will say concavo-convex hyperdensity seen. Like in this lady, this is left side and right side of the CT scan. So on the right hand side, we can see a concavo-convex hyperdensity. I'll say the history once again. The history is this lady, she is very religious. She gets up in the morning, she takes a bath, she goes to the temple every single day. Today, accidentally, she slept in the bathroom. Her head slammed against the wall. Initially, her son knocked on the door. He did not get an answer, but he kept on knocking, Mama, are you okay? Okay. So after 1 minute, she said, Yeah, I am fine. And when she came out of the bathroom, she was having a bump on the forehead also, which means that she would have had a subperiosteal bleed. Her son at that point itself said, Let's go and show a doctor. But the old lady refused to see the physician. And now, after 3 days or 4 days, they have come to the hospital because the lady keeps on sleeping all the time. This guy's son is saying that I never seen my mom sleeping. My mom is always very active. She gets up in morning and does all the routine chores. But the lady is drowsy. She's forgetful. She's exhibiting irritability. And the CT scan is showing a concavo-convex hyperdensity. Guys, the case that I'm describing before you is technically called as a subdural hemorrhage. This lady has sustained a subdural hemorrhage while going in the bathroom. Her head had slammed against the wall because she's a diabetic, so she could be having diabetic neuropathy. And due to diabetic neuropathy, there is loss of sensation in the sole of the foot. If you have loss of sensation, suppose you go to the bathroom and the floor of the bathroom is wet, you will be walking with care. But if a lady is having, she's a diabetic, she's a non-medical, she does not understand she's having diabetic neuropathy. So she's not having proper sensation in the sole of the foot and she accidentally slipped in the bathroom, then she can develop as a SDH, that is called as a subdural hemorrhage. The radiological finding of a subdural hemorrhage on a CT scan will be a concavo-convex hemorrhage. And this basically means that there is a bleeding below the dura mater. In the brain, subdural means the bleeding is below the dura mater. In this particular case, because there is a bleed below the dura mater, the patient will require a neurosurgical intervention. And usually they will ask you what is the neurosurgical intervention that will be done in this case. So I will give you two options and you need to comment on whatever you think is appropriate for this. This is an acute subdural hemorrhage. My options are, and I wanted to do a quick voting. One is burr hole surgery and the second is a craniotomy. So can I have quick answers, please? Yes. Burr surgery is one and craniotomy is two. Quick answers, one versus two. Quick answers. Okay, so I had like a mixed response. Most people were very vocal about burr hole surgery. So that is not the correct answer in this case. And that's the commonest mistake the students make. Burr hole surgery is answer for chronic subdural hemorrhage. At the moment, I'm teaching you acute subdural hemorrhage. So usually students are very tempted to answer burr hole surgery for all of these MCQs. Guys, in an acute subdural hemorrhage, it is a decompressive hemicraniotomy that will be a craniotomy that we will be doing. Craniotomy would mean that we will open up first the skull. When we open up the skull, we will be able to see the dura mater. The neurosurgeon will incise the dura mater, and below the dura mater will be the blood that is present. So they will do irrigation, and that brownish clot of blood will basically escape, the one that is pressing on the brain and is causing her to become drowsy and irritable. We will do craniotomy, we will incise the dura mater and do irrigation. When you do irrigation, the blood would have clotted in the previous few days. So that brownish clot of blood that was pressing on the brain parenchyma will gradually be removed and therefore the patient will improve. So for acute subdural hemorrhage, we do not do a burr hole surgery, we do a craniotomy. If the question is on chronic subdural hemorrhage, so how do I know it is chronic subdural hemorrhage is what I teach you next. In chronic subdural hemorrhage, the patient will present obviously late. This lady had come to me after maybe 2 or 3 days of falling in the bathroom. A patient comes to me, suppose after 3 weeks of having sustained a fall in the washroom. This lady 3 weeks ago had fallen in the washroom. After 3 weeks, she has come to the hospital because the complaints are that she keeps on sleeping for most part of the day. Her husband is saying that my wife is very active. I've never seen her sleeping, but for past few weeks, she's been very sleepy, drowsy. He is also saying that she's also very irritable. She's also very forgetful. Whenever you hear this kind of a history, drowsiness, irritability, and forgetfulness in any patient who has fallen in the washroom, you should always think in terms of subdural hemorrhage. Because the patient is coming after 3 weeks, anyway, I will advise a non-contrast CT head. If they ask you what is the investigation of choice for head injury, then do not answer MRI. I will teach you when to answer MRI, but at the moment, the imaging modality of choice for head injury is a CT scan. Can you tell me why MRI is not being done? MRI takes a long time to be done. If you've seen any MRI happening in your relative, it takes 30 minutes minimum for any sequence to be completed. But CT scan can be done in 2 minutes only. In head injury, I don't want to waste time. Nah, we can do MRI also. MRI sequences take minimum 30 minutes for any part of the body, MRI sequencing to be done. So we do a CT scan. CT scan can be done within 2 minutes. The scanner works very fast. So therefore, investigation choice for head injury is a non-contrast CT head. When we will do a non-contrast CT head in this patient, the image that will load up in the monitor will tell me that this is a chronic subdural hemorrhage. Once again, I'm showing before you the ventricles of the brain. This is where the pressure is elevated. This is the lateral ventricle. This is the third ventricle. Because the patient has come to me late, so now you will still be able to see the clot, but the clot that you will be seeing now at the moment will not be white because blood is getting reabsorbed. It's been 3 weeks, so you will notice that now the bleed that will be visible will be not white in color, it will be blackish in color. If they give you a non-contrast CT scan, in which in a patient you can still see a concavo-convex. If you look at the shape here, it is still a concavo-convex. But because it is black in color, I am calling it a hypodensity. Remember, in a CT scan, if something is white, then we call it hyper. If it is black, then we call it a hypodensity. If I see a concavo-convex hypodensity in a patient and it's almost 3 weeks, then I will say I'm dealing with a chronic subdural hemorrhage. While describing this, I would also like to mention regarding a Bollywood actor by the name of Hrithik Roshan. Hrithik Roshan, when he was shooting for this movie Krish, his head hit the side of a swimming pool. Because he's a fit guy, he neglected his symptoms, but he became started becoming drowsy, irritable. He became forgetful. Like an actor is supposed to remember his dialogues. So his dialogue director told Hrithik Roshan, man, what's happening to you? You are forgetting your lines. Like normally actors are supposed to remember their lines. Now only then they can speak the dialogues. So he was forgetting his dialogues. He was irritable. He was drowsy. He was not being able to do proper shooting. And his dialogue director told him that I think you are not well after the injury that you sustained in the swimming pool. So when he went to his physician in Mumbai, they did a CT scan. It showed almost a 50 cc hematoma, which was a chronic subdural hemorrhage. In chronic subdural hemorrhage, we don't open up the skull because prognosis is bad. In chronic subdural hemorrhage, mortality rate is 40%. So we do a burr surgery. Hrithik Roshan was very lucky that he was a fit guy, so he was able to survive. But he has undergone this procedure by the name of burr surgery. So burr surgery is the answer for chronic subdural hemorrhage and is not the answer for acute subdural hemorrhage. Is the message that I basically wanted to give you. And on the basis of this discussion, I want to tell you that they can also ask you that in boxing, which kind of bleeding in the brain can be seen. So in boxing or mixed martial arts, you would have seen nowadays in India also the craze of mixed martial arts has increased significantly. In mixed martial arts, these guys would be boxing with simple bare knuckles fight are there. So knuckles to the side of the head, elbows to the side of the head. This side of the elbow is really hard. No, if you hit somebody on the head, like somebody is fallen down, you hit somebody like this, then obviously the guy can end up with a nasty bleeding. See in Olympics, the boxing that they do, they use protective headgear. So the chances of injuries will be lesser. But in all these professional fights that you see on television nowadays, those mixed martial arts fights are really nasty. And now obviously like mixed martial arts was like, Brazil, Jiu-Jitsu and all those things, but now it's catching up in India also. So boxing, mixed martial arts can contribute to severe head injury in a patient. That would be chronic subdural hemorrhage. So whether they give you a case of a boxing or mixed martial arts at the end of a bout, or he says Alzheimer's disease patient fell in the bathroom, or he says Parkinson disease patient fell in the bathroom, or he says type 2 diabetes patient falls in the bathroom, or obese lady falls in the bathroom. Any of these situation that is given in the question, whether it is Alzheimer disease, Parkinson disease, because all of these neurodegenerative disorder patients have tendency for falling and they have sense of imbalance. MCQ can begin by saying Alzheimer disease, AD. PD is Parkinson disease, type 2 diabetes, obese people again, obese lady, she is very obese, she has a sense of imbalance, she fell in the bathroom. And then he says patient has become very drowsy, keeps on sleeping for most part of the day. Like this person's son is saying, my mom sleeps 6 hours per day, but now she's sleeping 16 hours per day. So normally mothers are always doing something. No? In our houses also, our mothers, even if they don't have work, they're still doing some cleaning, some clothes, something. And mothers are always doing something in our houses, right? But this guy says, sir, my mom is sleeping all the time. I don't know, I've never seen my mom so lethargic. And then she's also very irritable. Like fathers can be irritable. No, father working whole day. You talk to the father at end of the day, you gali denge, right? He'll abuse you, you go to hell, right? But mothers, irrespective of whether mother is herself sick, she will still talk very nicely to you. So this guy is saying like my mom has become very irritable. She's become very drowsy. I mean, any of this situation, if this is the kind of language in a question, you have to first and foremost understand, even if you don't note down anything else that I've told earlier, but if this is the kind of a history given in a question, it should immediately occur to you in a question that we're dealing with subdural hemorrhage. In all cases of query subdural hemorrhage, to confirm the diagnosis, what will the physician write in the casualty? NCCT head, that is non-contrast CT head will be done, because CT scan can be done very fast. MRI takes 30 minutes minimum. CT scan report will be available in at least 5 minutes. Now in the CT head scan report, two possibilities can be there. If the patient will come early, within few days of bleeding, then the bleed will be appearing white. But if the same patient will come to me late, then the bleed will be still having the same shape but will be black in color. So acute, how do I pick up acute is if it is white? How do I pick up it if it is chronic is if it is gonna be black? Obviously, I can put it a different way. If patient comes to me early, that is within, let me say, 3 days of falling in the bathroom, versus patient comes after 3 weeks of falling in the washroom. Like in case of Hrithik Roshan's case, he neglected his injury and he kept on suffering. And then his dialogue director told him, man, what's happening to you? You become so forgetful, you're forgetting your lines. And he was having headache also. So acute and chronic subdural hemorrhage can be picked up. Most of these MCQs will expect the answers from you as not acute and chronic. They will say what is the nursing plan for this patient. I mean, the nurse will be planning for what kind of intervention the physician will be advising for this patient. So if it is acute subdural hemorrhage in a person, then you will be transferring the patient to the OT. I mean, you as a nursing officer have to make the call to the OT to arrange the OT, because after all you have to book the OT now. In the hospital only few OTs will be there and there might be multiple surgeries going on. So you need to do a craniotomy in the patient. So book the OT immediately so that craniotomy can be done. But if it is going to be a chronic procedure, then again you will book the OT, but then it is not opening up the skull. Like we will not be opening up the head of the patient, but we'll be drilling a hole on the side of the head to decompress and reduce the pressure. And this burr hole surgery is done over the weakest part of the skull. This is itself an anatomy question of your exam, that the weakest part of the skull would be a bone by the name of, the area on the side of the head is what is called as pterion. So on the side of the head, this part of the skull is very thin. So we drill a hole on this part of the skull. No, if you hit somebody here, it really can be nasty. So pterion is the site, it is the weakest part of the skull. This itself is an anatomy question. Which is the weakest part of the skull? The weakest part of the skull is pterion. The weakest part of the skull is pterion. So burr hole surgery is done over Tyrion, that is the weakest part of the skull, and therefore there are two aspects I wanted to bring to you attention: craniotomy versus burial surgery, or the interventions that are done. And don't answer mannitol in this case. I will also tell you when do you give mannitol for raise ICP, but at the moment the objective was to tell you regarding what will be the language of the question of subdural hemorrhage. It will be either a sports related injury, boxing, mixed martial arts, Alzheimer's disease patient falling in the bathroom. Now I will change the perspective. And what I mean by changing the perspective is that I'm describing a Swiggy or a Zomato rider. You would have seen this Swiggy and Zomato riders, they are provided with a helmet, but they don't wear the helmet. They wear the helmet in the elbow. They're driving a bike and the guy is on his phone like this. They have given him earphones also, but he's on the phone like this. He's driving a bike and he's saying, "Okay, I'm coming, coming, coming." And you know this guy is a disaster because somebody even touches him a bit, the bike will lose balance. And Bengaluru roads are anyway bad, so the guy will end up with a head injury. So I am describing a Swiggy or a Zomato rider, and this guy was not even using the helmet. Most people in India think that helmet is only to prevent a challan. They don't understand it is for their own health. They will say, "Oh, I'm going to market 500 meters away now." But if that road is 500 meters having potholes and if the bike will fall, then the guy can impact on the head and can end up with extradural hemorrhage. So unfortunately, in this guy, there was a bike accident. Helmet was off. The guy was not wearing a helmet, or he was wearing the helmet on the elbow, as these Swiggy riders do. Now, unfortunately, when the bike skidded, like it had rained, maybe the road was wet, the bike can skid. So the head of this patient slammed against the concrete road. And when the head slammed against the concrete road, this guy had a cerebral concussion because of which he became unconscious. Because he became unconscious, therefore, like maybe normally in India, if somebody has an accident, nobody helps because of the police problem. People don't want to help. So some people did stop by, looked, but then they passed by. Some did stop, maybe made a video with a mobile phone and did an Instagram live. Maybe they tag Prime Minister Modi also that, see, you are responsible for this road condition in India, like that, right? Or Chief Minister of Karnataka, like something like that, right? After a few minutes, the guy regained consciousness. After a few minutes, the guy regained consciousness. He realized that he had an accident, so he decided to come to Bengaluru Medical College, where you are posted. And you saw a guy walking in with a Swiggy dress or a Zomato dress. He had bruises over his body because when you fall from a bike, there can be soft tissue injury also. So let me say I was the physician on duty, so I requested you, "Ma'am, sir, please get a MLC made of this guy because any accident case will come, you have to make a MLC, and then you also have to do dressing, etc. of the patient and maybe get tetanus toxoid injection for this particular patient. And for MLC, you will obviously ask the guy his name. You ask him his address, phone number. He told you everything. He told you his mobile phone number. He told you his mobile phone number, his address, his personal details. And you also noticed that he was maybe talking to his wife or maybe his parents on the mobile phone. He also told them that I had an accident. Like he told his wife, "Don't worry, I'm okay. I had an accident." And maybe he sent his location on WhatsApp to his wife also that, "Okay, you can come." And meanwhile, you got the MLC of this guy done. Now, this particular patient's wife has come to the hospital. She's asking me, "How is my husband doing?" So I was busy attending to multiple patients. I was the only resident on duty. So I went to the bedside of this guy, and his wife thought that he's sleeping. I also thought that he's sleeping. And when I tried to wake him up, the guy was unconscious. Few minutes ago in the casualty, he was conscious. The nursing officer on duty is saying he talked to me. He told me his mobile phone number, everything, everything. And now he's lying in the bed with totally like he's in an unconscious state. The GCS of the patient is beginning to drop. The patient will go into coma and can even die. What I wanted to bring to your attention is consciousness between two periods of unconsciousness that is called as lucid interval. What I wanted to bring to your attention is the statement of mine that there is a consciousness between two periods of unconsciousness. This explains the fact that anybody with a head injury should always be subjected to a CT scan before we send the patient back home. Lots of time in government hospitals, due to lack of facility, CT scan is not done and people die, go back home and they die. We must always do a CT scan in every head injury patient. And ideally in India, you see in a private hospital, obviously they will ask for money and money. Nobody has money, somebody has an accident, he may not have money available. So they'll send him off. Ideally, anybody in India who has an accident, government should be paying the money. Patient comes right now. If it's my hospital, my nursing home, government should pay money to the hospital. Now, the lack of money should not be the reason that somebody should not receive medical care. Because if something like this happens to our loved one or dear one, by the time we reach, we might lose the individual. Accident care should be a topmost priority, like myocardial infarction treatment, stroke treatment. Accident care should be a topmost priority. It should be free of cost for everybody. Obviously, in private hospitals, it is. In government hospitals, it is free of cost. It should be free of cost in private hospitals also. And all the cost should be borne by the government. I mean, whatever money is spent in the care of these patients, government should pay the hospital so that at least the person does not die. Half the time, private hospitals turn away these patients and therefore they can die on the way to the hospital, on arrival in the hospital. In this particular individual, if I will get a CT scan done, this guy was conscious a couple of minutes ago. He was talking to the nursing officer on duty very well. The nursing officer says, I myself saw him send his location on WhatsApp to his wife, and now this guy has suddenly become unconscious. What I'm showing on the CT scan at the moment is a bleed in the brain of this guy. The shape of the bleed at the moment I can say is idly shaped or biconvex. Earlier, I was using the word concavo-convex. Now I'm using the word biconvex. This bleed that I'm showing before you at the moment is a biconvex bleed that is putting pressure on the brain ventricles. As the hematoma will expand in size, it will put pressure on the brain ventricles and will also cause hydrocephalus. This bleed that is currently shown is biconvex in shape. This biconvex bleed that has been shown at the moment in MCQ can be written as lenticular because it looks like a lens. It is biconvex. It can be written as lenticular, or it can be written as biconvex. Hyperdensity. Remember my words. Bleeding will always appear white. If it's a bleeding that has occurred couple of weeks back, then it will turn black because blood will get absorbed. But initially, the blood will always appear white on a CT scan. So there would be lenticular or a biconvex hyperdensity, or you can call it looking like a idli as well. So idli shaped or lenticular biconvex hyperdensity is present. It is pressing on the ventricles of the brain. So you will notice I've shown one ventricle chota and the other ventricle relatively bigger. One of the ventricles of the brain is getting crushed and the other ventricle is getting dilated. So you can see hydrocephalus developing, obstructive hydrocephalus. This particular area that I've highlighted before you, where I'm putting a star mark, is the area where the CSF in the brain is present. Normal pressure in the brain, normal intraocular pressure is. Yes, normal intraocular pressure is given in Saunders as 5 to 15. In Harrison, the textbook of medicine is given as 10 to 20 millimeter of mercury. Don't bother about those units, but both books mention Saunders says 5 to 15 as couple of you prompted. Harrison says 10 to 20 millimeter of mercury, but both books come to the conclusion that what is the definition of raised ICP? The definition is more than 20 millimeter of mercury. If they ask you what is the definition of raised ICP, in the exam they will not ask you what is normal because normal values can change in different books. Some books will say 5 to 15, some books will say 10 to 20, but both books say one common thing. What is definition of raised ICP? More than 20 millimeter of mercury, and where the pressure getting elevated, that is where I put the star mark. That is the ventricular system is where the pressure is getting elevated, and this high pressure will squeeze the respiratory center. Due to gravity, this is the cut section of the brain. This is the cut section of the brain. Due to gravity, the maximum pressure will be on the brain stem. When the pressure in the brain will rise, it will put pressure on the brainstem, and brainstem is where the important centers of the brain are located. One of the important centers that is responsible for breathing, we call it respiratory center, and then we have a center for maintenance of blood pressure that is called as vasomotor center. Both of them will get compressed, and therefore the BP will crash and breathing will stop. When the pressure in brain will rise, it will result in brainstem compression because this is obviously one section of the CT scan, but due to gravity, you can understand when pressure will squeeze the brainstem. In the brainstem, we have respiratory center, we have vasomotor center. When respiratory center will be squeezed, the patient will go into apnea, respiratory arrest. And when the vasomotor center will be crushed, the BP of the patient will crash and the patient can die. So why raised ICP is dangerous is because it can squeeze the brainstem, it can crush the respiratory center and the vasomotor center. Even for that boy who was studying in Kazakhstan, I was saying that they did a lumbar puncture, he had a raised ICP. You are not supposed to do lumbar puncture in raised ICP. Lumbar puncture is contraindicated in the case of rise ICP. We should first give mannitol and lower the pressure in the brain. In that particular boy's case, they did not give mannitol. They put a wide bore needle. Suddenly, the CSF gushed out that resulted in brainstem compression. The boy went into respiratory arrest and he finally died. Brainstem compression is the sequelae which can occur in any case of head injury and can result in development of apnea and hypotension. It is not that this apnea and hypotension will develop immediately. Initially, you will notice that the patient's breathing will become like this, the way I'm showing at the moment. You will be noticing that the patient will be exhibiting hypoventilation. Hypoventilation means that the depth of breathing will be relatively lesser. Intermittently, you will notice patient will develop apnea. Apnea means cessation of breathing. Then patient will take few deep breaths, hyperventilation. You will notice that the patient will be exhibiting hypoventilation, apnea, hyperventilation. Then again this pattern will be repeated. Again it will be hypoventilation, apnea, hyperventilation. This pattern keeps on getting repeated again and again. If I put a line, I will say this once again. It was first hypoventilation because of the pressure on the respiratory center. Hypoventilation. Hypo V means hypoventilation. Then it will look as if the guy has stopped breathing for a few seconds, apnea. Then the person will be exhibiting hyperventilation. Hyper V means hyperventilation, and this pattern will be repeated again and again and again. If this is happening in a patient, you will be allowing the relatives into intensive care unit. Normally, intensive care unit is a sterile area and we don't allow anybody to come into an intensive care unit. But now you will be saying that the relatives are allowed because this may be the last afternoon that they see him breathing and alive. This guy might die today evening or maybe tonight. So we might be allowing the father or maybe wife or family members of this patient into intensive care unit. You obviously with cap on and gloves on and shoe cover on. Obviously ICU is a sterile unit, so obviously that routine precautions have to be taken with shoe cover and covering of the head and gloves, etc. But then the point is, chest-to-chest breathing always heralds bad prognosis, and implies that this patient will die maybe by today evening or maybe tomorrow morning. Chain-Stokes breathing is a line diagram that can be given in the paper. If chain-Stokes breathing is not treated, then the breathing will become like this. I'm now drawing the irregular breathing. Yes. Initially, I drew chain-Stokes breathing, which was having a pattern that is hyperventilation, apnea, hyper, hypoventilation, apnea, hyper, hypoventilation, apnea, hyper was getting repeated again and again. Chain-Stokes. But now I'm using the word irregular respiration. Now you can see that there is no pattern. It is just sometimes he's breathing, sometimes he's not, sometimes breathing more, sometimes lesser. This irregular breathing itself is a question of your exam. This is called as buyouts breathing. Raised ICP kills a man because it squeezes the respiratory center in the brainstem. Raised ICP kills a man because it squeezes the respiratory center in the brainstem, which results initially in chain-Stokes breathing and then buyouts breathing. And subsequently, the end sequelae of this would be that there would be no breathing occurring in a patient. That would be apnea. What I'm trying to teach you is that a person is gradually becoming brain dead. We first have chain-Stokes breathing, then it evolves into buyouts breathing, then it evolves into apnea, and the patient can die. This entire presentation that I mentioned here before you is called as extradural hemorrhage. This entire presentation, the clinical diagnosis will be. How am I saying the word extradural? Due to two words. One is lucid interval, and second is due to the biconvex shape that I'm trying to draw once again. That shape will obviously be because blood is white, so therefore it would be extradural. So therefore I'm showing it in color gray. How am I saying the word extradural is based on the biconvex shape that can be seen here, which is also written as idly shaped or lenticular hyperdensity. Basically, they started asking regarding raised ICP from the perspective of brain hemorrhage or head injury. So that's why I'm covering this. Extradural hemorrhage is the diagnosis in this case. In this extradural hemorrhage, he will also ask you what is the source of bleeding here. So the artery that is bleeding in this case is called as middle meningeal artery. Helmet must always be worn. We as medical personnel imply on everybody, you must always wear a helmet, whether it is cycling, even cycling, right? Because somebody falls from a cycle, even then the injury can be bad because when you fall suddenly, the impact occurs on the side of the head and the middle meningeal artery can rupture. In all of these cases, the patient has to be taken into the OT and they will have to first do a craniotomy, that is open up the skull to remove the bleed which is passing on the brain and is causing brain herniation and compressing the respiratory center. The MCQ will say burr hole surgery in this case also. MCQ will say craniotomy and will also say craniotomy with ligation or bleeder. Again in this MCQ, do not answer burr hole surgery. Do not answer plain craniotomy. Do not answer plain craniotomy. Your answer is craniotomy. The neurosurgeon will first open up the skull. After removing the bleed will come back again because artery is bleeding. So in this patient, the answer would be craniotomy with ligation of the bleeder. It would be craniotomy with ligation of the bleeder that would be occurring. So we need to do both the things here, craniotomy with ligation of the bleeder, by which we'll be able to manage this patient effectively. The type of bleed that I've explained here is called as extradural hemorrhage. There are two bleeds that I've explained at the moment. One is subdural, second is extradural. I'll describe one more case here. This guy was driving alcohol under the influence of alcohol. He had a car crash. This particular guy is comatose in my hospital. He is comatose for past 3 days. He is not waking up. He is not opening his eyes. His father and family members are pretty worried. They're saying our son is unconscious in your hospital for 3 days. When will he wake up? So I said I really can't comment at the moment. It may take maybe 10 days, maybe take 15 days. His father is saying, come on, sir. I mean, it's okay. You guys are charging so much for the hospital care. We can afford that care. But can you tell me when my son will regain consciousness? I said, sorry, I don't know. He says, no, I'm not satisfied with the treatment. I want to take him to Bengaluru. I want to take him to AIMS or somewhere. So I said, okay, you can. In this particular case, his son is also saying, you are not operating on my son. So I will tell him, sir, not all cases will require an operation. The case that I'm describing before you at the moment was a car crash. The guy was not using a seat belt. There are small bleeds in the brain parenchyma. There are small bleeds in the brain parenchyma of the patient. Like earlier, I was teaching you bleed with respect to the dura mater. It was either below the dura mater or it was above the dura mater. Below the dura mater is subdural, above the dura mater is extradural. But this time the bleed is in the brain parenchyma. These are small punctuate hemorrhages. You can notice in this particular case, these would be small punctuate microhemorrhages in the brain parenchyma. These punctuate microhemorrhages that I have currently explained to you, these punctuate microhemorrhages that are present are usually at the junction of the gray matter and the white matter. You are aware that outside in the brain will be gray matter. Towards the periphery would be the gray matter. On the inside is the white matter. At the junction of the gray matter and the white matter, most of the time these bleeds are present. When somebody is driving a car without a seat belt, then the violent jarring of the head, he had a truck impacted the car. The violent jarring of the movement of the head can result in these kind of microscopic punctual hemorrhages in the brain parenchyma. The diagnosis in this case is again a favorite of our examiner and is called as diffuse axonal injury. DAI is the case where the bleeding will not be with respect to dura mater. The bleeding will be in the brain parenchyma. These will be punctual hemorrhages in the brain parenchyma, that is diffuse axonal hemorrhages. I also want to tell you that sometimes these hemorrhages can be very small, that they may not be visible on the CT scan. The bleeding is there, but it is so small that it may not be visible on a CT scan. So don't be surprised that in the MCQ he may deliberately say CT scan is normal. Even if he says CT scan is normal, the bleeding is very much there. It is not visible because it is chota bleeding, 0.1 millimeter, 0.2 millimeter. So in some MCQs, deliberately examiner may try to trick you by saying a patient of car crash, head injury, was comatose for 3 days, 4 days, and CT scan is normal. The answer will still remain the same: diffuse axonal injury. There is no surgery that is required in this condition. It is conservative management. Conservative would mean that I will give mannitol for this patient. I will care of the back, care of the bowel, care of the bladder would be done in this patient. It is conservative management that would be required. What I mean by conservative management is in any unconscious patient, the first thing is always secure the airway. For securing the airway, I will be putting in this patient a cuffed endotracheal tube. The advantage of cuffed endotracheal tube is it will prevent microaspiration of saliva, because whenever we are sleeping, even when we are sleeping, we never aspirate our saliva. But if we are comatose, we can end up with aspiration of our own saliva. So cuffed endotracheal tube needs to be pulled and patient needs to be put on a ventilator. One of the primary interventions that is required for any patient who's comatose is secure the airway. Once the airway has been taken care of the patient, then second what we need to do is hemodynamic monitoring. So we need to monitor the blood pressure of the patient. So blood pressure monitoring would be required. I would like to keep the BP on the higher side. In all head injury patients, we deliberately keep the blood pressure on the higher side. We call it permissive hypertension because that improves the brain perfusion. I will give you a mathematical formula to explain this, which is called as cerebral perfusion pressure. Cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. Give me 10 seconds on the board and listen to the mathematics here. If somebody's intracranial pressure will rise, just look at it mathematically and tell me if intracranial pressure will rise in a patient, then what will happen to cerebral perfusion pressure mathematically? Lesser. You see, I'll write down values also. I had a couple of blank looks there. Mean arterial pressure is 95. Internal pressure is about 20. So cerebral perfusion pressure of you and me is about 75 millimeter of mercury. Now suppose I say somebody had a head injury and the ICP increases to 40, 95 minus 40, what will happen to mathematical value of perfusion pressure will become lesser? Because you know that cerebral perfusion pressure will become less. Because you know that cerebral perfusion pressure can become less, you will not allow that to happen. How can you prevent that from happening is that you can cause an increase of mean arterial pressure. I'll say the mathematics once again. If ICP rises by 20 points, if you increase MAP also by 20 points, then both will cancel each other. Pure maths, forget about nursing now. Pure mathematics, forget nursing here. If ICP rises from, let me say, 20 to 40, if you increase mean arterial pressure also from 95 to another 20 points, you can counterbalance the rise of the intracranial pressure. So what we do is we deliberately increase the mean arterial pressure. We deliberately increase the mean arterial pressure to counterbalance the raised ICP of the patient to maintain the cerebral perfusion pressure of our patient. So we can be giving vasopressors. The vasopressor that we can be using in this patient is like norepinephrine. Most students say, sir, we are not discussing septic shock. So why are you giving norepinephrine? I'm giving norepinephrine in a head injury patient to increase the mean arterial pressure. Look at the board and tell me, if you increase the mean arterial pressure, are you decreasing the raised ICP or are you counterbalancing the raised ICP? Counterbalancing the raised ICP. When you increase the mean arterial pressure, you counterbalance the raised ICP of the patient. So vasopressors were taught to you earlier for management of patients of septic shock. But now I'm saying that we can also be using it in patients of raised ICP. So we deliberately keep blood pressure on the higher side for management of these patients. Obviously, then it's going to be conservative care, like care of the back, because I don't want a decubitus ulcer. So what will you do is frequent turning of the patient. Patient should be turned every 2 hours. Patient can develop fecal impaction, so enemas might be required on daily basis. You might have to put a Foley's catheter in a patient, or you might have to put a condom cath. Wherever possible, we will put a condom cath, because if you put Foley's, then UTI risk will increase. Care of the back, the most important thing is frequent turning of the patient. Along with frequent turning, the mattress that will be used in the patient will not be a conventional mattress. It will be an air mattress or it can be a water mattress, which can take the contour of the body. By bowel, I mean I don't want fecal impaction, so enema might be required if I notice fecal impaction. For bladder, I will preferably put a condom cath in a patient and avoid catheterizing the patient. The advantage is that back, bowel, and bladder, I mean, lots of time comorbidities can result. I mean, bed sore if it will occur. Now imagine bed sore and patient urinates in the same bed, then the urine will contaminate the bed sore, that will cause sepsis. In this particular case, it is conservative management that is done. In this particular case, it is the conservative management that is done. There is no surgery required for management of patients of DAI, that is called as diffuse axonal injury, where microscopic punctured bleeds can be occurring. And the reason for this is violent jarring of the head, because when somebody is driving a car, another car slams into the car, where this guy was maybe driving the car under influence of alcohol. He did not stop at a red light. When he was jumping the red light, another car came and smashed into his car. So the violent shaking of the head, that violent jarring of the head can result in development of this kind of a bleed in a patient. The bleed that I described is called as diffuse axonal injury. Now I will describe one more bleed before you. This time the bleed that I will describe before you is because of hypertensive crisis. Like this is a known case of hypertension. In this known case of hypertension, there will be a bleeding in the brain due to rupture of a brain blood vessel. The case that I'm describing before you is that of hypertensive crisis. Hypertensive crisis is said to be present when BP is more than 180 by 120 and there is evidence of target organ damage. And there is evidence of target organ damage. Target organ damage would mean brain hemorrhage in a patient. This particular guy has hypertension. He does not take medicines for hypertension. Rather, he just laughs that off. And today, unfortunately, there's a rupture of the blood vessel in the brain. If I zoom into this diagram, I'm just showing a couple of anatomical structures which you don't need to draw. You just need to hear me out. Just adjacent to the lateral ventricle is present caudate nucleus. This caudate nucleus is damage to this causes an involuntary movement called as chorea. I'll be explaining how chorea looks like in a few minutes from now when I'm done with this topic. Adjacent to the third ventricle is an anatomical area in the CT scan, which is the pain relay center in the body. This pain relay center is called as thalamus. Morphine acts on the thalamus and cuts off the pain. Like we give morphine to patients of MI, we give morphine to gunshot victim. Soldier got hit by a bullet, so we give morphine to soldiers. That thalamus is the pain relay center in the body. Now I'm showing an anatomical area, which is the most common site where brain hemorrhage occurs. This area is called as putamen. Putamen is the most common site of brain hemorrhage. Putamen is the most common site of brain hemorrhage. I have shown a couple of anatomical areas like caudate nucleus, putamen, thalamus. Thalamus is the pain relay center in the body. So each of these anatomical areas have their own importance. Now I will be drawing a structure which is bisecting them. This is called as internal capsule. This anatomical area that I'm currently showing before you is called as internal capsule. This internal capsule has a anterior limb and has a posterior limb. The importance of this internal capsule will become visible to you in the next 1 minute. Present in the internal capsule are fibers that will be controlling the face and are fibers that are controlling our arms and controlling our legs. Each and every muscle of our body, is controlled by this area of the internal capsule where the face fibers, arm fibers, and the leg fibers are present. I am describing a hypertensive patient. He does not take medicine for hypertension, and today morning, you will notice mostly stroke occurs in morning hours, heart attack also occurs in morning hours. Can you tell me why does stroke occur in morning hours and why does MI occurs in morning hours? Vasoconstriction is maximum in human body in the morning hours. The BP tends to rise in the morning. When you wake up in the morning, your BP tends to rise, and hypertensive, the rise will even be more. When the BP of this guy was rising, it resulted in rupture of a blood vessel with respect to the putamen. So now I'm showing the bleed. When the bleed will increase in size, it will first press on the fibers that control the face. So the facial asymmetry of the patient will be noticed. This man was eating his breakfast at the dining table. His wife says that my husband's face suddenly started having face deviation. Then the bleed will press on the area controlling the arms. So because the wife noticed that husband's face was deviated, so she offered him a glass of water and she says something very surprising. You see, if I'm a right-handed person, If somebody will offer me a glass of water, I will take it from my right hand. But because this guy is having a development of weakness of the right hand, his wife is noticing that his wife is saying, Sir, I don't know what happened. She's a non-medical. She says that my husband's right arm suddenly went totally limp, like he could not use his right arm. He was trying to grab the glass that I was giving him of water with his left hand. So there is a facial asymmetry and a right arm weakness in this guy. Subsequently, the weakness in involved the trunk, and by the time they reach the hospital, the weakness in will involve the legs of the patient. This patient's half body will become paralyzed. First, face becomes paralyzed, then arm become paralyzed, and then trunk will become paralyzed. What I've described before you is the commonest variety of hemiplegia that you see in hospitals where half body will become paralyzed. We tend to call it technically as pure motor stroke. Pure motor stroke occurs due to involvement of P for pure motor strokes, involvement of the posterior limb. P for pure motor stroke, P for posterior limb of the internal capsule. The small blood vessels which are supplying this area had ruptured. In brain hemorrhage, you don't have rupture of large blood vessels. You have rupture of the chota blood vessels, which are going to be ruptured here. It is pure motor stroke is the presentation. In pure motor stroke, where is the lesion present? The lesion occurs in the posterior limb of the internal capsule. The clinical presentation in this guy will be, the question will say, the patient is a known case of KCO, means known case of hypertension. This known case of hypertension today morning at 8 a.m. He was sitting at the dining table when there was a development of sudden onset phase deviation. The face of this patient, you are aware that in the brain everything will happen opposite. Like if the bleeding is occurring on the left side of the brain, then face of the right side will become deviated. So there will be a sudden onset right-sided face deviation. There will be a development of right arm weakness and development of right leg weakness. Initially, she noticed only arm weakness, but when she reached the hospital, she noticed he could not get out from a chair. Like he had to be taken on a wheelchair to the casualty inside because he was having a right leg weakness also. So whenever you read this kind of history, known case of hypertension and sudden onset face deviation, arm weakness and leg weakness is occurring, we are dealing with pure motor stroke. We are dealing with what happened to Dhirubhai Ambani, the father of Mukesh Ambani and Anil Ambani. He was the richest man of India. He was a known case of hypertension. In spite of the fact that richest man in India had hypertension, he did not take medicine for it and he developed hemorrhagic stroke. In casual words, we will say brain hemorrhage. And then in Dhirubhai Ambani's case, when he was taken to the hospital, he started having that chain strokes breathing, then he started having bites breathing, and finally he died. Ambanis are rich people. They called in doctors from America. But in spite of that, I mean, Ambanis are rich people. No, they can call anything. They can call a hospital to anywhere they want, right? So they said Indian doctor not good. We'll get American doctors. Still, he could not be saved. Hypertension is a silent killer. That itself is a question of your exam. Which disease is a silent killer? Hypertension is a silent killer. This is a question of more of PSM, I would say. Hypertension is a silent killer and hemorrhagic stroke is a sequelae that can happen. Ambanis are rich people. No? You would have recently seen Ambanis, they invited Messi. So Messi came to India, right? And then they gave that 18 crore watch to Messi. And after wearing that watch, then Messi was doing that prayer. Right? You putting a tilak and then he was doing 18 crores, right? Speaking there, no? Ambani is the rich people. If they can Messi to India, they can do anything. But anyway, if you've seen any picture of Dhirubhai Ambani, none of his pictures are having a full frontal view. It's always one side face that have shown because he had stroke 2 times. First time stroke had only face weakness. So because of that face weakness, frontal picture will not look good, no? So if you do Google of Dhirubhai Ambani sir's picture, you will notice that all pictures were like this, right? Side cut of the face is shown. Any picture on internet of Dhirubhai Ambani sir is a side cut of because first time when he had stroke, there was only face deviation. And subsequently, he developed that half body paralysis. And subsequently, when the pressure in the brain rose, then you cannot do anything about it. So prognosis is bad in this case. Hemorrhagic strokes are 90% cases die within 2 months of diagnosis of hemorrhagic stroke. Either they die immediately due to raised ICP or they will die because of complications like aspiration, bed sore, or maybe UTI or pneumonia. Then he will say, what is the drug that will be used in this particular patient to lower the BP? This is very commonly asked in your routine, that day-to-day test, that TOT test that they consider. Nicardipine is the calcium channel blocker that will be given to lower the BP in this patient. Must know MCQ for this neuro emergency today. Drug of choice for hypertensive crisis. Drug of choice for hypertensive crisis causing brain hemorrhages, nicardipine, that will help in lowering of blood pressure. If nicardipine is not in the options, then you're supposed to answer labetalol. Nicardipine or labetalol is the drug of choice of hypertensive crisis by which you will be able to lower the pressure in the brain of this patient. So at this moment, I wanted to bring to your attention one more case presentation for brain hemorrhage. CNS hemorrhage is what I wanted to speak about. Let me just summarize the informations that I have given you for brain hemorrhage or CNS hemorrhage. The first type of bleeding that I spoke about was subdural hemorrhage. Then I spoke about extradural hemorrhage. And right now, in Dhirubhai Ambani's case, where I showed a bleeding in the brain, we call it intracerebral hemorrhage. I also discussed a case where small microscopic bleeds can be present, that is called as diffuse axonal injury. What will be the words in the MCQ that you will immediately pick up subdural hemorrhage will be, if he says patient had a fall in the washroom, followed by development of gradual onset drowsiness and irritability. The best way to remember subdural hemorrhage is to remember case of Hrithik Roshan. Drowsiness, irritability, forgetfulness. He started forgetting his dialogue lines is the main word to remember for subdural hemorrhage. The bleeding in this particular case will be appearing concavo-convex. This is optional. If you can remember the radiological findings, great. Otherwise, you can forget the radiological findings, but you should be able to immediately make a nursing diagnosis if you read a question saying fall in the washroom, followed by development of drowsiness, irritability, and forgetfulness. If I change the question and say that the guy was having a motorbike accident, helmet was off. I have emphasized time and again, I'll say this once again, most people in India decide to wear a helmet just because they want to avoid a traffic challan. They don't realize that they are simply playing with their life. Just look at the kind of driving that people do in India on their bikes. They've never studied science. They don't understand physics, etc. What is impact? But at least the least they can do is put on a helmet so that at least if they fall, then the chances of head injury would be substantially reduced. I mean, we usually as healthcare professionals educate them, do it at least for your family, not for yourself. No, because young guy will say, oh, no, nothing will happen to me. You say, okay, nothing will happen to you, but when you will go, then your ailing parents and wife and children will suffer. No? Young guy, when you say, oh, come on, man, you are afraid, right? I mean, they're going to be cool dudes, right? So they'll make fun of you. You are afraid. You don't need to. You people keep on talking safe things, and nothing will happen. You say, for the sake of your parents, do it. Intracerebral hemorrhage will always be hypertensive crisis. Among all the scenarios that I'm giving you, the most important one that should never ever be forgotten is intracerebral hemorrhage, because this is a silent problem in India, hypertensive crisis. It will begin with development of headache. And then he will say sudden onset phase deviation. See, guys, I have already written this. I'm doing the hard work of writing it again so that I can emphasize the importance of this to you guys. That hypertensive crisis, headache with sudden onset, face weakness, arm weakness, etc., and the bleed in this case will be ill-defined diffuse bleed. This bleed will press on the posterior limb of the internal capsule. This will be a diffuse bleeding in the brain. The diffuse bleeding in the brain will press on the posterior limb of the internal capsule and will cause contralateral face paralysis, arm paralysis, and leg paralysis. The last entry will talk about a car crash. Like this guy, he thinks he watches a lot of Hollywood movies where they show drag racing and all those things. He thinks it is he's Van Diesel. right? All those Hollywood movies, no? Hollywood movies, Tom Cruise, they're driving all they walk away from a crash. That's how they show, no? Walking away from a car crash. It's never possible in reality. It's only in a movie. Hollywood movies, they you show a hero walking away from a crash. So in this particular case, there is a car crash. The guy is comatose for 2 days, 3 days, and family members are saying hospital is running a scam. They are, you put the guy in intubation, no, and you have to sedate the patient. They're saying I saw the nurse giving injection. They're deliberately keeping my son under sedation. One guy recently on social media, he made a video. Nurse was giving that propofol to the patient. So saying they're deliberately giving propofol. They don't understand what is propofol. They say they're deliberately keeping my son under sedation because they want to charge 1 lakh rupees for the hospital bed every single day. They don't understand the importance of intubation. No? If you have to intubate somebody, you will first have to sedate the patient and keep him under sedation as well. You have to give neuromuscular blocking agents also. So car crash, comatose for 3 days. That means the patient has to be anyway intubated. Once again, I would like, though I did not say it, but you guys can comment here. What is the indication for intubation? Glasgow coma scale value less than how much? Less than 8. Indication for intubation is Glasgow coma scale value less than 8. Any value of Glasgow coma scale less than 8 by 15 means that the patient will not be able to secure his airway. He will not be able to swallow his own saliva. Intubation is indicated in every patient with GCS less than 8 by 15. The patient cannot secure airway. Patient will not be able to swallow his saliva. It will all go in the lungs of the patient and there would be a bacterial pneumonia developing in a patient. So that is why securing of the airway is important. And when you intubate somebody, then you might have to give medicines to the patient to keep the patient sedated and at the same time give muscle relaxants also. The names of these drugs I would just like to mention before you, like we give propofol, we can give succinylcholine, we can give rocuronium. These drugs are taught to you in pharmacology, propofol and rocuronium. Rocuronium would be a neuromuscular paralytic agent. Both of these drugs are required for RSI. RSI stands for rapid sequence intubation. When you have to intubate somebody fast, then the drugs that are given in rapid sequence intubation are propofol and rocuronium. I'll correct the spelling of rocuronium. Meanwhile, you guys can just note the word RSI. That is it was U here, rocuronium. Rapid acting hota hai. Rocuronium begins with R, so it's one of the most rapid acting muscle relaxants. Rocuronium is a rapid acting muscle relaxant. Propofol will anyway knock out the patient. Just out of curiosity, I'm asking you, if you give IV injection to somebody, like you give propofol to somebody, then patient will lose consciousness within how many seconds? What is the arm to brain circulation time? You start giving propofol to somebody here. If I give propofol injection to a person here in the dorsum of the hand via cannula, the drug will obviously flow into the bloody circulation, go in the heart will pump it to the brain. How much is the normal arm to brain circulation time? Got my question? No? Arm to brain circulation time. Arm to brain would mean arm, heart to brain. Arm to brain circulation time is 11 to 15 seconds. Like you would have seen in the hospital, doctor giving anesthesia. So when you give anesthesia to the patient, we ask the patient to do counting or do singing. Like we say counting 10, 9, 8, 7. By the time they reach 5, out, lights out, right? You don't even count till 0. I'm saying if you have seen propofol being given, you ask the patient count 10, 9, 8, 7, 6, by 5, lights out. That's how fast acting it is. Because you want to knock out the patient and do a fast intubation. Why you want to do a fast intubation? Because in any surgery, if you are doing intubation slow, if patient vomits, everything will go in the lungs. Ideally, for any surgery, patient should be minimum fasting for 8 hours. As nursing officers, your responsibility is any elective surgery. Patient should be fasting for minimum 8 hours. Patient should not be allowed to take even a sip of water. Even in a hot Indian summer, you will say not even a sip of water. But in emergency surgery, patient might have had a meal 1 hour ago. No? Now it's lunch time. A guy had a meal 1 hour ago. He had a head accident. If he comes to the hospital, I will not say, no, we will do surgery in late evening. Got my point or not? In elective surgery, patient has to be fasting for minimum 8 hours. Not even a sip of water is to be taken by the patient. Even if it is hot, you can apply some ice, etc. But not even a sip of water, because God forbid, when the anesthesiologist is trying to put the tube, if patient has consumed even water, tea, etc. Indian patients always सा चाय पिया था, बिस्किट खाया था, लंग्स में चला गया ना सर. It goes in the lungs, na. The biscuit will go in the lungs, the दूध will go in the lungs, चाय will go in the lungs. That is how they talk, ना. थोड़ा सा मैं पानी नहीं पिया था, चाय पिया था, दो दो घूंट चाय पिया था. चाय सुबह तो चाहिए ना चाय पिए. तभी तो एज नर्सिंग ऑफिसर्स आपका रिस्पॉन्सिबिलिटी होता है पेशेंट को. जितनी इलेक्टिव सर्जरी का पेशेंट, एवरी टाइम यू गो, कुछ खाया तो नहीं, कुछ पिया तो नहीं, वो बार बार यू वुड सी नर्सेज आस्किंग द पेशेंट, गोइंग आफ्टर समटाइम्स पेशेंट विल, हाउ मेनी टाइम्स विल यू आस्क, यू विल स्टिल से नो, आई विल आस्क यू. Your Indian patient psychology is like that, na sir. They say chai pee liya, something, something, or they'll have something, and then it ends in the lungs of the patient. In emergency surgery, somebody had tea or lunch maybe 1 hour ago. He had a bike accident across this road. He comes to my hospital. Then obviously his stomach is full. Now, when you're intubating this guy, then everything that he ate will go in the lungs of the patient. So I need to be fast. No, that is why I'm teaching you these drugs. That is propofol and rocuronium will knock out the patient, and therefore we can intubate, because muscle relaxant will relax the body. So it's easier for you to insert the laryngoscope, get the access, and get the tube in place. And we also do a maneuver which I will say verbally called as Salix maneuver. In Salix maneuver, you will be pressing on the cricoid, not thyroid. You press on the cricoid cartilage. When you press on the cricoid, you obliterate the lumen of the esophagus. If you obliterate the lumen of the esophagus, think logically and tell me, even if the person will vomit, if you obliterate the lumen of the esophagus by putting pressure on the cricoid, chances of aspiration will be same or lesser? Lesser. Just for the sake of it, if you want to note down, you can note down Salix maneuver is done in emergency intubation. Salix maneuver is done in emergency intubation, where you as an assistant will be putting pressure over which cartilage? Will you be putting pressure over the thyroid cartilage or cricoid cartilage? Cricoid pressure. It is cricoid cartilage pressure. What this cricoid cartilage pressure will do is it will cause a obliteration of the lumen of the esophagus. Because of the obliteration of the lumen of the esophagus, the good news is that now in the patient, even if he will vomit, the chances of vomitus going in the lungs will be relatively lesser. And then one more thing I told you, that we will always put cuffed endotracheal tubes. That cuff that is deployed will also form a seal. The cuff will form a seal and will again prevent aspiration of the contents present there. So Salix maneuver is anyway important from the perspective of emergency medicine, that we put a cricoid pressure, obliteration lumen of esophagus, and we decrease the risk of aspiration pneumonia. This aspiration pneumonia is actually written as aspiration pneumonitis, because as such what will happen is that there would be stomach acid going in the lungs of the patient. Can you tell me the technical term for aspiration of stomach acid? Very good. Mendelssohn syndrome. This itself is an important terminology that I expect everybody to know. What is Mendelssohn syndrome? Your answer is Mendelssohn syndrome is aspiration of stomach acid. When stomach acid will go in the lungs of the patient, it will cause chemical pneumonitis, because it's hydrochloric acid that is going in the lungs of the patient. This, yes, I would rate it as an important statement, Mendelssohn. Rest is taught in emergency medicine, anesthesia also, but I wanted to say must know fact for today is Mendelssohn syndrome is aspiration of stomach acid. The objective was to sensitize you to the fact, for any elective procedure, fasting for 8 hours with not even a sip of water. In emergency, you can't obviously control that, because somebody had an accident 1 hour ago, half an hour ago. If I have to take him in the OT, he might be full stomach also. And then I have to do, obviously use drugs and go in for Salix maneuver, so that the chances of aspiration in the patient can be significantly reduced. Also, I mentioned that we use a cuffed endotracheal tube. We always use a cuffed endotracheal tube. So they will ask you the pressure in the cuff. Yes, 30. It should be less than 30 centimeter of water. The pressure in the cuff is regulated by the pilot balloon of the endotracheal tube. The cuffed endotracheal tube pressure, the cuff pressure should be, the question will say, cuff pressure should always be less than 30 centimeter of water. Why less than 30? What will happen if you inflate it to 40? What will happen? What's the problem? Tracheal mucosal ischemia. The objective is to reduce tracheal mucosal ischemia Because the tracheal mucosal ischemia will occur, then there subsequently will be a complication called as tracheal stenosis. Remember, we were discussing now intubation should be ideally done electively, not more than 7 days, because the cuffed endotracheal tube will cause damage to the tracheal mucosa. Remember the mathematical value, cuffed endotracheal tube, the balloon pressure would be less than 30 centimeter of water that can be regulated by the pilot balloon of the endotracheal tube. Tracheal mucosal ischemia is a complication that will occur. What I mean by the word tracheal mucosal ischemia is the subsequent complication of tracheal stenosis. So endotracheal tube is coming in the discussion again and again. So I'll just highlight the fact, two minimal points I want you to remember for today is that anytime endotracheal tube is put, GCS should be less than 8 because patient will not be able to secure his airway. Though I hope I've been able to communicate to you, can you tell me what is difference between a unconscious patient and a comatose patient? Unconscious patient due to hypoglycemia is also unconscious. Comatose patient is also unconscious. Both are lying with their eyes closed. Both are not responding to your commands. Both cannot tell you the name. So what is the difference between unconscious patient versus comatose? Got me a question now? Some diabetic patient, his sugar became very low, so he's lying with his eyes closed, unconscious. There's a head injury patient who's also unconscious, lying with his eyes closed, but I'm calling him comatose. So what is the difference between unconsciousness due to hypoglycemia? I'm getting the point, right? Diabetic patient took insulin or he took oral hypoglycemic drug sulfonylurea, sugar became very low, became unconscious. And then a head injury patient is said to be comatose. Which patients are unconscious? What is the difference? Sir, if a patient is unconscious, you can just listen to this. If patient is unconscious and along with this, the important airway protective reflexes are absent. Airway protective reflexes, as I explained to you, are gag reflex and the cuff reflex. Meaning of the word coma is that unconsciousness is obviously there. But what is the additional thing present in the patient? The additional thing is that the airway protective reflexes in the patient will also be absent. That is, gag reflex, cuff reflex is absent. If these two things are present together, unconsciousness and gag reflex, cuff reflex absent, we call it coma. And we have a mathematical, that Glasgow coma scale available, where we do eye opening, verbal response, and motor activity. That eye opening, verbal response, and motor activity will be having values of E4, V5, and M6 as the maximum score. And you know that the minimum score possible is 3, the maximum score possible is 15, and comatose is defined as score less than 8. The mathematical score that we have to attain is less than 8, equal to or less than 8 for saying comatose in a patient. So technically the meaning of the word coma is what I tried to highlight before you. That is GCS of less than 8 is the most accurate description for it. In all head injury patients, you are supposed to obviously evaluate the eye opening, verbal response, and the motor activity. I mean, you are supposed to evaluate all of these parameters in a patient. If you go to the bedside of the patient and the patient will do spontaneous eye opening, like you go to the bedside of the patient for changing the bottle of IV fluid or giving any injection, if there is a spontaneous eye opening in a patient, you give 4 marks. This is optional, you can listen to. But if you go to the bedside of the patient and when you are giving IV injection, patient did not open the eyes, so you called out the patient by name. If you call out the patient by name and they open their eyes, then on command, then you will say 3 marks. But if patient will not open his eyes on going to the bedside and not even on calling out the name, then you will be giving pain. How would you give pain? How do you give pain? Okay, options, right? One is punch. Punch him in the face. Second is sternal rub. Sternal rub, right? Sternal rub, is that how you do that? In a government hospital, yes, but is it looking nice? Guys lying and you on the front of family is like, wake up. Doesn't look good, now. So how do you do that, right? Sir, you have to be discreet. So either you press on the nail hard with a pen on the nail. You're not supposed to do sternal rub, sir. That is not recommended anymore. Either you press hard on the nail or you press on the trapezius muscle. You hold this muscle here, traps, right? Trapezius. Squeeze hard here, gently. Family members should not be able to see. Put it on yourself. If on my mom and my dad, if you're gonna do like this, I'll say, Hato. Obviously, no. Somebody does that to your mom and dad. Would you like it? No, no. So they have asked this that how do you give the pain stimulus? Sir, we don't do a sternal rub anymore. Though I thought you were aware of this, but anyway, let's do this. How do you pay it? Either the pain is given on the nail bed. Or it can be given on the traps, that trapezius pinch you can do. You can do a sternal rub, but doesn't look very nice now. Doing it to a patient who's not well, I mean, it looks a very unpleasant thing for the family members. They're already emotionally aggrieved. If there is no response, then there is no zero. Obviously, we will be saying it is no response. Then we go for the verbal response in the patient. We go for the verbal response. The maximum score possible is V5. So if a patient is able to, you go to the bedside and patient starts spontaneously talking, like he says, hospital is a horrible place. I don't like this place. You guys are so depressing. You guys hardly smile at all. Just looking at your face, doctor or nurse, I'm feeling so sad. Discharge me. So if the patient is doing a routinous chit chat, like spontaneous talking, I can say that would be V5 in a patient. But when it comes to verbal response, V4, V3, V2, then obviously the progressive deterioration would be happening in a patient. For spontaneous talking, I can put in a different way. You can listen to this. I can say patient is well conscious, like the patient was talking to me. Na? He is conscious and oriented in time, space, and person. Like he's talking to me, he's saying, now it is afternoon, I've come since morning. He himself says that I'm in the hospital and he says, please discharge me. So he is recognizing himself. He knows that you are a healthcare provider. So patient is conscious, oriented in time, space, and person. That would be like V5. But if the patient is confused, like you asked him a leading question, what time is it? He cannot tell you the time. He does not know where he is. He cannot tell you his mobile phone number. That confusion that comes in would be V4. If you ask the patient, where are you? And he gives you some choicest abuse in the local language, that would be inappropriate words. Inappropriate words basically means like you are asking him his mobile phone number so that you can call his relatives, but the patient is literally abusing you with some choicest filthy abuse. Then inappropriate word would be V3 in a patient. Inappropriate. P alphabet will come 3 times, so that is V3. In contrast, when the patient will be just doing mumbling, like when I ask this patient, what is your name? What is your mobile phone number? Is just doing like that, right? So that mumbling part or mooning part that is coming up. You see difference between 3 and 2 is that in 3 at least you could pick up that he's abusing you. But in 2 you cannot pick up anything. No? It's just doing like that. So mumbling or mooning is present in a patient. So in the question they will always give you these situations where you expected to pick it up, and in the hospital because you do it regularly you are able to pick it up. So one, I said conscious, oriented in all the 3 things: time, space, and person. If he's confused in anyone, it's not confusion for all 3. It is confusion in anyone. If he cannot tell, he cannot tell you his name. He cannot tell you whether he's in home or hospital. Any one of these, if it is like wrong answer, that means he's confused. So we say V4. V3 is gonna be like inappropriate words. V2 is mumbling or moaning, and then is like V1 where there would be no response. And then obviously there was a question in your exam where the patient was intubated. If somebody is intubated, then we say VNT. NT means if somebody is intubated, you cannot test it. So you will say the word non-testable. NT stands for the word non-testable. NT stands for the word non-testable. Then comes the aspect of motor activity. In motor activity, the patient can follow the commands, like you will ask the patient, move your big toe or move the little finger of your right foot. We will not ask the patient to move hands, etc., because lots of time we put IV cannulas. So patient will move his hands, etc., then IV cannulas and lines can get dislodged. So we can say, move the big toe of your right foot, make the little finger of your right foot. So follows commands would be a score of 3, a score of 6. That is follows commands is motor response of 6. But if I tell the patient, move the big toe of your right foot, move the big toe of your left foot, he's not able to do this. So I will gently pinch the patient. And if the patient can localize the pain, a patient can localize the pain, like I am putting pressure over the trapezius muscle. Like I said, move your big toe, move your big toe of your right foot, move the big toe of your left foot. He could not move it. So I give him a pinch over the trapezius muscle and he's pushing my hand away. That's localization of pain. That is localization of pain. So M5 would be a value for localization of pain that you need to remember. Difference between M6 and M5 is in M6, he can like raise arm. He can follow any commands that you give. In M5, he will not follow the command. So you will give a painful stimulus. Painful stimulus, he will try to push away. That is localized pain. Then would be M4, M3, M2 onwards, which you obviously have to pick up in the question. For M4, I will be asking the patient, like I will ask the patient, can you move the big toe of your foot? He will not be able to do it. So I will give a painful stimulus. When I will give a painful stimulus to the patient, he will not be able to push my hand away. He will not be able to, like earlier I was giving painful stimulus, so he was pushing my hand away. Here I will notice that he might just raise his arm. But he will not be able to localize the pain. Like here he can localize the pain, right? M5 is localization of pain. He will push your hand away. But in M4, you will notice that he will not be able to localize the pain. So not localization of pain. There might only be an arm movement happening, but he will not be able to localize the pain. Most questions will be having answer as M3 and M2. For M3, not localize the pain, the word that will be written in the question will be the older words here were decerebrate. The older words in the question were decorticate and decerebrate posturing. Let me write down the older words, please. Decorticate and decerebrate. Nowadays, we don't use these in the MCQ, and most of your MCQs in the paper revolve around M3 and M2. So try to remember either of the two that I tell you. In M3, the word that will be written will be abnormal flexion. He will say abnormal flexion in the MCQ. Try to remember at least one for today. If you read a question in Glasgow Coma scale where he says the word abnormal flexion, then you will say M3 variety, M3 score. If he says the word abnormal extension, I will show you images of the same also, so you will be able to knock more sense into it. But at this moment, the minimum I expect you to remember is the values M3 and M2. Try to remember one of the two at the moment. That is at least the minimum I expect you to remember right now is that M3 score that I said. That is an abnormal flexion. That's the terminology. I'll show you images for the same also. How does decorticate posturing look like? How does decerebrate? But at least one of the two should be remembered. And obviously M1 will be no response. When you will do this in the hospital on a regular basis, this will become second nature for you. But at the moment, I just want to say is that, I mean, when you are like, doing it for first time, it might be looking a little overwhelming. Just to see you got me or not, I will be putting up a question before you, which will look very funny. But anyway, calculate the GCS of a dead person. That would be 3, no? Because GCS score cannot differentiate between live and dead. Calculate the GCS of a dead patient, the score will turn out to be 3/5 because GCS score is not designed to pick up live versus death. So that's the bias that is present here. That's the bias that is present here. Let me change this. I have an intubated patient in my hospital. This intubated patient at the moment is speaking inappropriate. This intubated patient is doing the following activities, which is abnormal flexion and is having spontaneous eye opening when I went to the bedside. Today morning, I went to the bedside of a patient. There is a spontaneous eye opening present in the guy. There is an abnormal flexion that I'm noticing on a motor response and the patient is intubated. Can you calculate the GCS of a patient? Intubated will be NT, not testable. Agreed? Yes or no? Intubated, you cannot check the verbal response in a patient. Abnormal flexion in a patient, that would be a score of M3. And spontaneous eye opening present in a patient. Help me out, guys. That would be 4. So total score would be 7 NT in a patient. This might look overwhelming initially, but when you are going to do this on a regular basis, the questions will become easy for you. My suggestion for you is that if you were not able to follow even a single of this point, you need to practice this at least once by yourself, especially like the minimum I expect you to know right now, right here is the following information where students make errors. They make errors in the paper between V3 and V2. You will notice in V3, I said inappropriate word, so you could at least pick up the cuss word. And in V2, like you could not make up any word, that is mumbling and moaning. So in the language of the question, you have to identify that is he speaking a word that is having some meaning. It may be a wrong word, it might be abusive word, but at least that word has some meaning. But in V2, the word does not have any meaning. Similarly, the errors come between M3 and M2, that is decorticate and decerebrate, which is abnormal flexion and extension respectively. How to remember that? Decerebrate E alphabet is coming again and again. So extension, extension. Just pick up the alphabets E come again and again because because otherwise, like at the moment you will say, huh, okay, abnormal flexion, abnormal extension. Exam people answer opposite of that. So you need to figure out a way to remember. So decerebrate would be an abnormal extension that would be present. So these are a couple of parameters on GCS which I thought I should mention. And anyway, I've described the aspect of raise ICP before you from the head injury perspective. Just saying one more point, and then we go for a lunch break. Mannitol was not even talked even once here. There is no the mannitol in any of the situations that I mentioned. Mannitol is contraindicated in case of active venous bleeding. Guys, if somebody is having a active venous bleeding and I give mannitol, it will increase the bleeding paradoxically. Mannitol is contraindicated in active venous bleeding. If I give mannitol to somebody who's having actual bleeding in the brain, the bleeding will paradoxically worsen. So though in government hospitals, they just give mannitol to everybody. In actual reality, we don't give mannitol in active venous bleeding, guys. So how do we lower the pressure in the brain is what I just introduced to you. In raise ICP in a patient, if he says what are the steps which are to be used to lower the pressure in the brain, then what we do is we put a catheter in the ventricle of the brain. We put a catheter in the ventricle of the brain and we remove the CSF from the ventricle of the brain. That is called as ventriculostomy. Ventriculostomy is what is called as external ventricular drainage. We put a catheter and we remove CSF from the brain of the patient to lower the pressure in the brain parenchyma. Ventriculostomy should be remembered by you as future nursing officers as the most effective method. Most effective method to lower raised ICP is ventriculostomy, where we put a catheter in the brain and we remove the CSF. Now, obviously, in government hospitals, we will not have facility. So he says that in government hospitals, because you don't have or you have limited resources, you can use osmotherapy. Osmotherapy would mean that you can use drugs like mannitol, which is a hypertonic solution. Now, obviously, even a first year nursing student knows that mannitol is given for raise ICP. So in your NORCET exam, they have asked what fluid can be given to patients of raise ICP. Your answer will be 23% saline. That is hypertonic saline that is given to the patient that will remove pressure from the brain, that will remove water from the brain and will reduce the pressure. The opposite MCQ of this that they've asked is which fluid should never ever be given in patients of head injury and raise ICP? This is a very favorite question of your examiner that which fluid is never ever to be given, because 5% dextrose when you administer, it becomes a hypotonic solution and this hypotonic solution will rather worsen the swelling in the brain. You can give hypertonic, but you're not supposed to give a hypotonic fluid. Hypotonic fluid is a big no because it will worsen the swelling in the brain. I'll rate this as one of the super important statements for today. What you can give in a patient is mannitol. What you can give in a patient is 23% saline, but what you should not be giving is 5% dextrose. Apart from this, other medicines that can be used to lower the pressure in the brain, that's just from the pharmacological domain here. Other medicines that can be given is IV acetazolamide. Acetazolamide is also used in management of angle closure glaucoma. Angle closure glaucoma, we use acetazolamide to reduce the pressure in the brain. Then we have a drug which can be given with help of NG tube that is called as glycerol. I've taught you a couple of drugs which are called as osmotherapy. Osmotherapy would be like mannitol, 23% saline acetazolamide, and by NG-tube glycerol can be given to reduce the pressure. All patients of head injury or raised ACP should be nursed in a head and elevated position. This basic nursing procedure is not followed in government hospitals because we are always short on staff. And you will notice head injury patients die within few hours of arrival because even the basic nursing position is not happening. Head end head end of the patient should be elevated. Most people are under impression the head end will increase the pressure of the brain. No, raising the head end rather lowers the pressure in the brain. It is supine that will kill the patient. This would be semi-Fowler position. He will say, what is nursing position? Nursing position would be head and elevation. Remember my statement, for heart failure patients and head injury patients, it should always be head and elevation. Remember my statement, head injury patients and heart failure patients, the head end should always be elevated. Supine position will increase the mortality in heart failure and head injury patients. Then you need to intubate the patient and secure the airway. For intubation and securing the airway, you should be using rapid sequence intubation. The drugs that can be used for rapid sequence intubation have already been taken care of. That milky solution that is in soybean oil, that's what the question was. Milky solution, it looks like milk. Propofol injection looks like milk. It's in soybean oil emulsion that is called as propofol. Propofol is a medicine that is commonly used even before daycare surgery. If you are assisting in endoscopy of a patient, propofol will be given. We give propofol before endoscopy. We give it before bone marrow biopsy, bone marrow aspiration. Basically, daycare procedures. And obviously in patients of raised ICP as well. Before endoscopy, bone marrow biopsy procedure, daycare procedures, we can give propofol to the patient. The advantage is propofol has a short duration of action and within 1 to 2 hours patient will regain consciousness. Like suppose if I have to do endoscopy in a patient, I can do endoscopy. Before that I will give propofol. Patient will sleep. After 1 hour he will wake up and he can even drive back home. I'm saying a very big thing. Patient after upper G endoscopy can drive back home. Propofol effect will last for only a few hours only. So after the endoscopy procedure is done, patient can walk back. So propofol is routinely used for rapid sequence intubation that I've already told you, RSI, before upper G endoscopy and daycare procedures. RSI, upper G endoscopy, bone marrow biopsy, and daycare procedures is where propofol is used. Along with this, we will also be giving muscle relaxants to the patient. I would like you to study the pharmacology of muscle relaxants by yourself. The drugs are succinylcholine, pancuronium, rocuronium. There are many of them available. Pancuronium, vicuronium. Rocuronium is rapid onset action. R for rocuronium, R for rapid onset. That is again a pharma question, which is the most rapid acting neuromuscular blocking agent. That muscle relaxant and neuromuscular blocking agent is rocuronium. So we need to keep the patient's body relaxed and also use drugs for sedation. We will also put the patient on ventilator. Once the patient is on ventilator, we will deliberately keep the respiratory rate on the higher side. All patients of head injury, when they are on a ventilator, we deliberately hyperventilate the patients. You guys tell me, when you hyperventilate, just follow the English words here. Hyperventilation will cause carbon dioxide retention or will it cause a carbon dioxide washout? I deliberately want a carbon dioxide washout because studies have shown that carbon dioxide washout decreases the rate of CSF production. I want to decrease the production of CSF, and if I decrease the rate of production of the CSF, then pressure will not rise further. Though I made myself clear, please help me. Point number 5. Is it actually lowering the pressure or is it preventing the further rise of pressure? Preventing. Is it decreasing the pressure or is it preventing the further rise? Preventing the further rise because you are decreasing the rate of CSF production. What is the rate of CSF production, by the way? It is 20 ml per hour. CSF is produced in our choroid plexus at a rate of 20 ml per hour. If you are going to decrease the rate of production, then CSF pressure will tend to reduce. Sir, I'm saying physics. The rate of CSF production is 20 ml per hour. Total CSF present in our brain is about 150 ml. The rate of CSF production is 20 ml per hour. Total CSF in our body is 150 ml. It keeps on getting produced. If you decrease the production rate, I'm saying if you decrease the volume, then pressure will also decrease. Mathematics, no nursing here. If volume decreases, then pressure will also decrease. So that's what is called as elective hyperventilation. So we deliberately put the patient on a ventilator because patient can't breathe on his own if you give muscle relaxant. But then we keep the on the dashboard respiratory rate on the higher side to decrease the pressure in the brain. So these are a couple of strategies by which we can decrease the pressure in the brain. Apart from this, obviously we have surgical procedures which I have mentioned, and I would just like to mention as tier 2 therapy. What I mean by tier 2 therapy is we can do surgery and we can do a decompressive hemicraniectomy. If we will open up the skull, obviously, like the pressure in the brain will go down. Decompressive hemicraniectomy can be done or craniotomy can be done, and that is a surgical procedure by which the pressure in the brain can come down. Today taught you 6 methods by which the pressure in the brain can be reduced. The first one, if he says what is the most effective method, the answer is the catheter we were putting. Ventriculostomy, that is called as external ventricular therapy. Because not all hospitals will be having facilities, so we can give osmotherapy for the patient also, and then a couple of backup procedures that I mentioned. In fact, one more I have taught you. I will write this formula again. Cerebral perfusion pressure is a difference of mean arterial pressure minus intraocular pressure. So those who could not follow mathematics, I give you one more opportunity. If pressure in the brain will rise, CP will decrease. I don't want the CPP to fall, so I will be ensuring a mean arterial pressure rise when MAP will also rise. Imagine ICP rose by 10 points from 20 millimeter to 30 millimeter, and MAP increases from 95 to 105 millimeter, then it will counterbalance the rise of ICP. It will counterbalance the rise of ICP. The medicine that I can be using to increase the mean arterial pressure is vasopressor. That vasopressor that I'm using is like NORCET. So you will notice that in the MCQ, even norepinephrine will be used. Help me out here. Is it actually lowering the pressure in the brain or is it counterbalancing the rise of IC? Counterbalancing, English here, right? Counterbalancing. It's not lowering the pressure. It's counterbalancing the rise of ICP. And what are you trying to maintain? Which pressure? Cerebral perfusion pressure. Normal cerebral perfusion pressure is 60 to 80 millimeters of mercury. That's our target, guys. If we are able to maintain in our hospital, I mean, what is the target? What is the target of nursing care in raise ICP? Then target of nursing care is cerebral perfusion pressure should remain between 60 to 80 and intraocular pressure should remain less than 20. If we are able to achieve this, our patient will live, otherwise he will die. In the entire CNS, this is the story. If you are able to maintain a cerebral perfusion pressure in the range of 60 to 80, and you are able to keep the pressure in the brain less than 20, no head injury patient, no trauma patient will die in the hospital. And if these parameters are not satisfied, then patient obviously will die. The primary objective, this is the main focus, right? Mathematics here. And how do you measure the pressure? We put a catheter in the brain. We drill a hole in the top of the head, we put a catheter, and we are able to prevent mortalities in our cases. Okay, fine. So it took a little longer than what I anticipated, but anyway,